Hello.
Hello. Hi, this is Dr. Neena Malhotra.
Hello, madam. Ma'am, can you please on your video?
Okay, yeah, I can on my video. Is this okay?
Yes, ma'am. Yes.
You give me a background of this thing.
Yeah. So, initially, I am Dr. Sangeeta. I'll be the MOC person.
I joined. I've already joined. Joined. Yeah. No, can you keep the background the same, because or I'm looking very dark in this. Just remove the background. I'm looking very. I can't recognize my face.
That I think actually sir has said the thing.
Sir is sent. So you know what? I even joined as a through the. Sir is sent to everybody. Chalo, it's okay. If sir is sent, we'll follow sir. Sir is the boss.
For me, I'm not able to apply that. Now. That is.
Yeah, even Kunju. Hi, Kunju. You have the same background as mine. I said the background is making us look very dark. We've just come back from Africa. Can we change the settings? I'll ask these people. We all are looking. You are looking very dark.
Yeah.
Maybe we light. Can we lighten the background? Means the background is the same. We just light the color, make it little dark. Otherwise, we are.
Basically, these are the two logos of Kfog.
Yeah. Ask her. Let's ask Sangeeta. Sangeeta, how do you feel? How are we both looking?
And I had expressed this before also that the background is big.
You know what? The logo should remain. We can put it like we do in animation, little muted tone, which we call it little dull tone. You know what? It remains the same. The knowledge, the KFOG remains, the knowledge edge remains. But those, what do you call it? Muting in the color. When you do an animation, lightning, you lighten the color. You make it, the person is, you can do it next time. So now what is happening? Kunju and me are looking like cartoons. Am I right? You look very dark in complexion. Just shifted from Ghana.
Let me clean my camera. Yeah. No use.
No use. Chalo, we are okay.
Looking great.
But it's also nice. You get the whole theme of the knowledge edge come. So nicely. So how has it been, Kunju? How has the day been? A lot of cases, a lot of patients,
No,
lot of surgeries.
Monday, no, it's quite busy.
Yeah, Tuesday. Monday, Tuesday is always busy.
Yeah, Monday used to be at Perinthalmanna, and Tuesday I used to come to Calicut.
Oh, how much is the drive? How much you drive?
No, I have a driver, but it takes 2 hours.
It is hectic.
Because the traffic is too much. Otherwise, the distance we can cover in one hour.
Yeah. I think between Kerala cities, there is no village. There is only city and city life.
Yeah, it's like a town.
Yeah, it's all town.
Banana Republic.
It is most urbanized state is Kerala. There is no village in between. Every area is urban now.
Yeah, exactly.
But it's beautiful to drive. The countryside means so-called.
Now it is raining also.
Yes, it begins in remain. So is it the right time to come?
No, better not, because see, the heavy rains are being expecting at next few days.
Oh.
Sir, Reggie sir has not joined it, no?
Yeah, he has not joined. Can you give him a call?
Yeah, sure.
Basically, Neena ma'am, we used to have this Kfog Edge webinar. We have divided the entire Kerala state, 15 societies, into 3 zones.
Okay.
And each zone has 5 societies each. And we have almost 6 specialized committees.
Okay.
So these committee chairpersons will be conducting a webinar with each zones. So this is the sixth one, and we have planned 23 of this, and
Oh my God.
5 is over.
Fantastic. You've been fast.
Yeah, because we have 2 webinars every month. Then only because I want to finish it in my tenure of 11 months, because we get almost 11 months only, not even 12 months as the presidential. 12th month it is the All Kerala Congress, and the next person will take in charge.
So All Kerala Congress is November, right? You have it in November sometimes.
No, February. Every year it used to be in February. Hi, Sujitra ma'am.
Hi.
Yeah.
Good evening.
Dr. Sujitra is our next president.
Hi, hello, Dr. Sujitra.
Hi.
Nice to see you.
Nice to see you too, madam.
Nina ma'am, it is for imaging committee, no?
Yeah, imaging committee, imaging.
When is the last date for nomination?
Is 31st, just 2 more days.
2 more days, yeah. Because Calicut is easy to cover. 3 webinars if you attend, you will.
Oh, that's very nice.
Yeah.
So anyway, I can do something on imaging, basically.
Yeah.
I should make something on imaging, maybe obstetrics or something on RH, something which is what we do quite often, regularly is something.
Because next webinar will be the academic committee, that will be basically for PGs. So that will be in the first week of June.
Okay.
Dr. Lakshmi, good evening.
Yeah, good evening. I'm not able to join with my laptop, so I've just logged in with my mobile phone. I'm not able to see all of you.
Yeah.
But you look perfectly normal. Good evening, sir.
Good evening. Hi, Reggie, your name has been changed to Hari.
Oh, sorry. Yeah.
You joined in
Reggie, you're using whose laptop? Change your name.
No, ma'am. I just, yeah. Good evening, madam.
Hi, how are you, Reggie?
Good evening, all of you.
I will log out and log in again.
Dr. Lakshmi is the president of Calicut Society.
Hello, madam. How are you?
Hello. Yeah. Hello. Good evening.
How are you? Good to meet.
Yeah.
It's good to meet. You're virtually connecting everybody thanks to these laptops and
Yeah,
thank you to this
definitely.
Zoom. COVID taught us only one good thing. Only good thing came was Zoom, right?
And hope you remember ours was the first CME.
Yours was the
after
first,
COVID.
and I was the first to come on that pregnancy. Remember, I
Yeah,
put that pictures in my this thing.
Yeah. There are 2 Lakshmis. How come?
Yeah, that's because I've logged in with my laptop. I'll just leave this.
Yeah. Other one you can leave.
Sir, by when we can start, sir? Like another 10 minutes or something?
Yeah, Reggie is joined. Sujitra madam is there. I think we can start.
At 7 o'clock, no? Sharp.
It's 7 o'clock.
Yeah, it is 7:01.
Wait for
701.
wait for some few more minutes so that
No,
the president.
No, we need to start because it's already some 40 people are waiting.
Okay. So shall I start, sir?
Yeah.
Okay. So good evening, everyone, beloved seniors, dear colleagues and friends. Good evening, one and all. I'm Dr. Sangeeta from Kannur, and as the MOC for the day, I'll be guiding you through the event
Yes,
and
ma'am.
hope to make it a knowledgeable and an enjoyable one.
Hello, ma'am.
So before we embark upon the event proper, let's seek God's blessings in the form of a silent prayer for the smooth execution of the webinar. Thank you, everyone. So this webinar is the sixth in the series of the webinars conducted by the Kfog committee, Reproductive Medicine Committee, and this time it's in conglomeration with the Kasargode, Kannur, Wayanad, Calicut, and Perinthalmanna ONG societies. So to brief us more on this webinar held by this reproductive medicine this time, may I now invite the chairperson of the committee, Dr. Reggie Mohan. Sir, on the slide is shared here.
Okay, one second.
Dr. Reggie Mohan is working in the reproductive medicine department in SAT Hospital, Government Medical College, Trivandrum, and he is currently as the chairperson of Reproductive Medicine Committee Kfog and the state coordinator of Food and Drugs Committee FOXY, and the former chairperson of Academic Committee Kfog and former editor Kfog Journal. Over to you, sir.
Yeah. Very good evening to all of you. Thank you, Sangeeta, for those kind words. Let me start. Respected Kfog President, Dr. Kunju Mohiddin, sir, Dr. Subhash Malaya, our Honorable Secretary, then our guest of honor and of our webinar, Dr. Neena Malhotra, ma'am, Professor Neena Malhotra, ma'am. Then all the distinguished presidents of Kasargode, Kannur, Calicut, Wayanad, and Perinthalmanna societies. Then welcoming all the dearest speakers, Dr. Hari, as well as Dr. Priya Bhave from Madhya Pradesh. Then all the chairpersons and experts who have consented to attend this webinar, and I welcome all my friends and my colleagues and dear delegates to this wonderful webinar. First of all, let me congratulate our turbo president. I would like to call Kunju Mohiddin as a turbo president because he is the one who is igniting the spirits of all the chairpersons and all the committee members by initiating all sort of programs like webinar, what all YouTube channel, what all, everything is there. So I will call him as the turbo president of Kfog now, which is one of the latest movies in Malayalam industry. And he has made us all very active. And as chairperson, I am deeply indebted to Dr. Kunju Mohiddin as well as Dr. Subhash for arranging this, our own wonderful speakers like Dr. Priya Bhave and Professor Neena Malhotra and Dr. Hari Kumar Ji. And I would like to again tell about Edge webinar that is actually earmarked one very important thing. That is, it has started. It has got a very enormous viewership now itself. It is only 6th program, but it has got an enormous viewership. And again, I would like to thank Subhash and Kunju Mohiddin sir for this arranging this Zoom platform also. And so Dr. Sujitra Sudhir madam from Kannur, who is the incoming president, she's also very active. She's the convener of this webinar series, Edge webinar series. And my own friend and colleague, Dr. Sangeeta, for being my master of this ceremony. And about the webinar, I would like to tell that as all of you know that as practicing infertility specialist, or as you start practicing the infertility specialist, as you know that ovulation induction is the basis or the stepping stone of every infertility specialist. So once you master this ovulation induction agents and how to induce ovulation and all, you can really build mansions on those things. So as rightly chosen by our president, Dr. Kunju Mohiddin, ovulation induction needs the basics and the practices should be thorough before starting infertility practice. So he have chosen the right topic. I think all the speakers are very well-known and renowned speakers, especially Dr. Hari, Dr. Priya Bhave, and of course, Professor. We are really honored to have Dr. Professor Neena Malhotra, madam, to this webinar. And I would like to welcome you all for this wonderful webinar, and hope it will be fruitful and give you some insightful thoughts about ovulation induction. Thank you, Sangeeta. Over to you.
Thank you, sir. Thank you for those great words. And next, may I request Dr. Kunjumoideen, President Kfog, to address the gathering and render the presidential address and introduce the chief guest to the gathering. Kunjumoideen sir is having more than 25 years of experience in ART and gynecological endoscopic surgeries, and he's the managing director and chief consultant at ARMC IVF Calicut and Perinthalmanna. And he's the present Kfog president. He is also the chairperson of Kerala chapter ISAR 2022 to 2024, and past joint secretary of IFS, founder president Perinthalmanna ONG Society, and former consultant at Maulana IVF. Over to you, sir.
Yeah, good evening, everyone. My respected chief guest, Professor Neena Malhotra ma'am, the Kfog Secretary General, Dr. Subhash, Chairperson, Reproductive Medicine Committee, Dr. Reggie Mohan, the presidents of Kasargode, Kannur, Calicut, Wayanad, and Perinthalmanna societies, dear colleagues, all the faculties, and dear delegates. At the outset, I really appreciate the efforts of Dr. Reggie Mohan to compile a webinar of this sort with a very important and the people are eagerly waiting for such a topic of ovulation induction, which is relevant for each gynecologist practicing the reproductive medicine. Even the basic concepts have been discussed so far a lot in the lot of webinars and discussions, because actually the field is flooded with webinars. But here we are just discussing not an ART topic, but it is something beyond basics of ovulation induction, so that we can take all the basic principles of ovulation induction to the next level. Along with that, we will be having an interesting panel discussion of the real-time case scenarios as well as the experiences of a very senior person, Dr. Neena Malhotra. So, can I see Dr. Neena's CV, or Reggie, can you stop sharing? Yeah, I can see. So I would like to introduce our chief guest, Professor Neena Malhotra. She is currently the professor and head of the Department of Obstetrics and Gynecology at the prestigious All India Institute of Medical Sciences, New Delhi. And she's head of WHO Collaborative Center for Research in Human Reproduction, president-elect of Indian Fertility Society 2024 to 26, and currently the senior vice president of IFS. And she has the Commonwealth Fellowship, Boysacat, I think the pronunciation is correct, fellow, and ICMR DHR International Fellowship for Fertility Preservation from France. And she has been awarded with a lot of awards. Of this, the most important ones are Sir Malcolm Black Fellowship in 2015 by the RCOG London, and Overseas Fund 2010 and 2019 from RCOG London, and Imaging Science Award by Foxy in 2006, and CS Dawn Award by Foxy in 2009, 10, and 11, and Korean Research Award in 2010 by Foxy. And she has an immense experience as well as interest in research in endometriosis, fertility preservation, and ovarian tissue cryopreservation, and funded projects, currently running the projects funded by ICMR Task Force on GTB, PCOS, ovarian tissue cryopreservation, and stem cells in atrophic endometrium, and an immense experience in publishing journals and over 135 papers in peer-reviewed journals. And at this point, I would like to mention that she is also the candidate for the Foxy Committee Chairperson for the Imaging Science. And I personally request all the presidents who are being part of this webinar, the Calicut, Kannur, Wayanad, the Kasargode, and Perinthalmanna Society President, to send in the nominations for supporting Dr. Neena, because we want the academics to come to forward rather than a lot of politics to happen. And she'll be the right person and best academic person, because I know personally, because I have worked as a joint secretary of IFS while she was the secretary of IFS in 2022, I remember. So that time I was closely worked with her, very much interested in all academics. So please support her and do send the nominations. And the nomination last day is 31st of this month. You have only 2 days. So with these few words, I request Professor Nina ma'am to address the gathering and inaugurate this webinar. Please.
Good evening, everybody. Thank you so much, Dr. Kunjumoideen, for those nice words. I think I'm truly honored, and it's my privilege to come in this evening to see so many friends' faces. Dr. Malaya, Subhash Malaya, Reggie, I think Dr. Priya is there, Dr. Lakshmi, Dr. Smitra, and to a lot of, gratitude to all the presidents and secretaries of societies as Kasargode, Kannur, Wayanad, Calicut, and I can't pronounce this very well, but I will try. It's Perinthalmanna. Am I right, Dr. Kunjumoideen? My pronunciation is not good. Thank you so much for giving me this opportunity at the very right time as I am contesting for the elections. But needless to say, I think we all have our way of looking at life. I think a lot of us believe in becoming rich. Yes, we do. We invest in shares, we invest in property, we invest in gold, and obviously we are looking at returns. But I think there's nothing as good as investing in knowledge, because what knowledge gives you is what money can't buy. And I tell you, what you truly get as returns with knowledge is true friends like you, because you are not just getting friends which you can't get, true academic friends. And that's something which I say, which really comes with knowledge, is humility. Because when you try to prepare and share knowledge, you realize how little you know. Because every day the world is of evidence-based medicine is adding so much new knowledge that you realize, yes, you need to read more, need to share more. And I think at the end of this day, I will go back not just enlightened by sharing, but learning from all the speakers and all the colleagues who are around there. I congratulate Dr. Kunjumoideen for this very, very mighty endeavor that he's sharing knowledge to his well-programmed, well-envisaged, well-designed, sessions that he's conducting across Kerala through all the societies across the year. And I can see the spirit of the Kerala societies who are coming forward, brimming with the numbers, as you can see, in participants, because on a weekday to get such a good number is a testament of his hard work, a testament of his, I would say, fame, and the kind of love that it showers to friends and colleagues. So once again, I congratulate, and I look forward to a very nice evening of good deliberation and good learning. Thank you very much.
Thank you so much, ma'am, for those inspiring words, and wishing you all the very best for your future endeavors. Following, now I request our beloved Dr. Suchitra Sudhir Madam, the State Coordinator for the Kfog, to speak a few words. Dr. Suchitra Sudhir Madam is a senior gynecologist practicing at Ashraya Hospital at Mattanur, and she's next president of
No, you are in the other box. I can see
she has been the president of Kannur ONG Society, and
I will share the link.
Chairperson and Vice President of Kfog 2020, editor of Kfog Journal 2021 to 23, and Survey Chairperson of Kfog 2023 to 24, and President-elect of Kfog 25 to 26. She has been bestowed upon with many numerous awards also. And over to you, madam.
Thank you, Sangeeta, for that nice introduction. Good evening to all. It is indeed a pleasure to see that the Kfog Edge webinars are rolling forward very smoothly, keeping all the chairpersons and societies on their toes. I thank Dr. Kunjumoideen, our president, for making me the coordinator for these webinars. I have found that each time we contact the chairperson in a particular society, they rise to the occasion, and each person is coming forward with a lot of innovative ideas and making these webinars something very special. And we are really honored today to have such an eminent personality as Dr. Nina Malhotra as our chief guest. And I'm sure she will come forward in a greater way in FOGSI. We are all looking forward to that. And also the galaxy of enthusiastic speakers and experienced chairpersons from all the 5 societies. So wishing you all the best, and let's have a great time at this webinar. Thank you once again. Sangeeta, you're muted.
Oh, sorry, ma'am. I had a call. Okay, thank you so much. So I now request the individual society presidents to render the felicitations and address the gathering. To begin with, may I request Dr. Omana Madam, President of Wayanad Society. She is of Kfog, member of Practical Obstetric Committee FOXY and Vice President IMA and Chief Coordinator of Pradhan Mantri PM SMA scheme. Over to you, Madam.
A warm good evening to all. My special respects to all the distinguished guests today, all the panelists, and all the chairpersons. Let me first congratulate my own Kunjumoideen and Subhash for this very for this very expert program of Kfog Veg program. I'm attending almost all the programs, and I see that each program is superior to the previous ones. Let me let me congratulate, and we'll see there are almost 120 members logged even now. That is so important to the peripheral practicing obstetricians, madam. So let me wish all the best for today's webinar, and congratulations again to our president and secretary, and especially Reggie, who has taken so much pains of share madam, and we have shared in all the societies. So all the best, and I'm sure at the end of the webinar, you'll be very much enlightened. Thank you very much.
Thank you, ma'am. Next, may I request the Perinthalmanna Society President, Dr. Kochu S. Mani. She is the Senior Consultant at EMS Memorial Cooperative Hospital and Research Center, and she's the present President of Perinthalmanna ONG Society, and she has been an invited faculty at various state and national conferences. Over to you, madam.
Okay, can you hear me?
Yes, ma'am. Yes, ma'am.
Can you hear me? Yeah. All
Yes,
the respected dear senior members and faculties, panelists, a very good evening to one and all. It's really indeed, it's a pleasure to attend such a program, being the president of Perinthalmanna Obstetric Society. I really appreciate Dr. Kunjumoideen, Dr. Malya, and Dr. Reggie, and all the organizers of this EDGE program. So making such a very interesting, and it's very helpful for all the practicing obstetricians and gynecologists to this one to enrich their knowledge and to share all the information from the panelists and the very expert speakers. Indeed, it's a great program, and I wish all the very best to all the organizers, and my sincere thanks also. Thank you.
Thank you, ma'am. Thank you.
Thank you, ma'am. Next, may I call upon Dr. Lakshmi S. She is the additional professor and Department of OBC Government Medical College, Calicut, and she is the present president of the Calicut ONG Society, and she's also been as the president of Calicut Menopause Society and vice president of Calicut ONG Society, honorary secretary, Calicut Menopause Society, and she has also been
can be cut short. Dr. Sangeet.
Okay. So
Very good evening to one and all. The Kfog EDGE series is a wonderful academic initiative by Dr. Kunjumoideen, Dr. Subhash, and the entire team. And I consider this a great honor and privilege on behalf of the society to be associated with this program. And today, Dr. Reggie has wonderfully organized this program. It's indeed a pleasure to meet so many stalwarts and in this field, and to share knowledge with them. I wish this program all success, and thank you once again for giving us the opportunity to be a part of this webinar.
Thank you, ma'am. Thank you, ma'am. Next, may I invite Dr. Geeta Mekot, the president of Kannur ONG Society. She is the senior consultant working at Dhanlakshmi Hospital, AKG Hospital, and BMH Hospital, Calicut. Over to you, madam.
Good evening to all the distinguished members and leaders. We are extremely thankful to Kfog for giving Kannur Society this opportunity. Congratulations to the organizers for making this outstanding webinar series truly remarkable and enlightening. It is an invaluable opportunity to meet and interact with all the members, with all the leaders. Thank you so much. Wish you all the best.
Thank you, ma'am. Last but not the least, may I call upon the Kasargode ONG Society President, Dr. Vidya Nambiar, She is the consultant at Health Workers Polyclinic at Vidyanagar and Kasargode, and Krishna and Janardhan Hospital at Kasargode. Over to you, madam. Hello.
Sangeeta.
Sir, she's not there.
Sangeeta.
Okay.
I think she's not there, but anyway, I will take upon it and thank everyone because we short. I think we'll cut it short. It's already 20 minutes. As my friend Dr. Georgie said, maybe politically wrong, but then I thank everyone here. Let's start with the meeting. Thank you very much. Thank you very much.
So that was the inauguration function, and so without much of a delay, let's kickstart with our event on the topic Mastering Ovulation Induction Beyond the Basics for Everyday Practice. Hoping the scientific session will chart it out will be of help to each and everyone gathered here. First topic is on the session is on ovulation induction agents, and to chair the session, may I invite Dr. Usha Menon. She's a renowned IVF specialist and endoscopic surgeon and is working as medical director at Venus Women's Clinic, IVF Center, Kasargode. She has been a faculty in numerous state and national conference, and special field of interest are in infertility, cosmetic gynecology. Next, we have Dr. Jayakrishnan KB, who is working as senior consultant and infertility specialist at JK's Fertility Clinic, Perinthalmanna, and visiting consultant at VKM Hospital at Mancheri. His field of interest are infertility and high-risk pregnancy. And next, we have our own beloved Dr. Bhavya AB, the consultant gynecologist at Aster MIMS, Kannur, and visiting consultant at Nucleus Hospital. She is also the vibrant secretary of Kannur ONG Society. And to talk on the topic, we have our esteemed speaker, Dr. Hari Kumar Ji, and I request our chairperson, Dr. Usha Menon, to introduce our speaker to the gathering.
A warm good evening to all of you. It's such a pleasure to introduce Dr. Hari Prasad. Can I have his CV? Yeah. So he did his MBBS from Calicut, Trivandrum Medical College, and MD from Pondicherry JIPMA, and fellowship in reproductive medicine. Can you put the CV? Yeah, fellowship in FNB in reproductive medicine from Women's Center, Coimbatore, and he's a consultant in reproductive medicine. At present, working in NSART Kollam from 2009 onwards, and he's a very great friend of mine. Over to you, Dr. Hari Prasad. Please present your.
Hari Kumar.
Yeah,
Hari, are you there?
Oh, sorry.
Yeah, I am very much. Consequently, can you help me?
Yeah, you can share your screen now.
One second. Sorry.
By the time Dr. Hari gets it right, I would like to acknowledge the presence of a few of the team members, Dr. Ramani Devi Madam, Dr. Prasanna Kumari Madam, Dr. Sujamol Shekhar, and a few seniors who have already joined us. Thank you, seniors and friends, for joining us.
Can you see my screen?
No, Hari.
No. Not there.
Not yet, sir.
Yeah, you can you?
No, you have to go down, share the screen.
Okay, one sec. Okay.
You are logged in with your personal link, no?
Yeah, fine. Yeah, is it visible?
Yeah.
Yes, sir.
Are you presenting from mobile, Hari?
Yeah, Dr. Kunjumuddin, I'm sorry.
Yeah, that's why the slide is very small to see.
Yeah, fine. Put up with me for today.
Yeah.
Yeah, first of all, let me thank Kfog Reproductive Medicine Committee, Dr. Kunjumuddin and Dr. Reggie in particular for giving me this opportunity. Am I audible?
Yes, sir.
Yes.
Yeah, fine. Today I'm going to speak about the ovulation induction, and I'm confining myself to the oral ovulins. I think you are in for a better lecture by Dr. Priya Bhave regarding the gonadotropins. So these are my references. So coming to how will you choose the ovulation induction agents? So one size doesn't fit everybody. So you have to choose your drug and the protocol based on the availability of the resources, affordability, to maximize effectiveness. So everybody wants pregnancy at the earliest moment. And the most important thing is primum non nocere, do no harm. That should be our motto. So what for we are doing this ovulation induction? Our goals are, in an ovulation, it's induction of a single follicle. But when it comes to the unexplained infertility, you want more than one follicle to come up. And obviously, there is a controlled ovarian hyperstimulation for IVF, which doesn't come under the purview of this talk. So coming to the anovulation, there are three groups, as everybody knows. First is the hypothalamic dysfunction, where oral ovulogins are not effective. So I'm not going to deal with that. Next is the ovarian failure, group 3, where obviously ovulation induction is ineffective. So my focus will be on the 90% of anovulation, which falls under HPO axis dysfunction. And brute majority comes under PCOS. And second group is unexplained infertility. Dr. G, am I audible?
Very well audible. No problem.
So the treatment starts with lifestyle modification. So we want to make sure that patient is optimized. Health should be optimized. BMI should be and 25, and she should be free of addictions. And for that, we can give them a very good counseling and make sure we are setting them achievable goals like 5 to 10% reduction over the next 6 months. Don't stop with saying them, cut down on your 20 kg excess and come back. They won't. They will go for an next doctor. And give them small tips like, you do extra 10,000 steps a day, whether it be on your workplace, on kitchen, or backyard, wherever. So those small tips matters. Then comes the treatment. There are obviously two groups. One is selective estrogen receptor modulators. That means clomiphene and tamoxifen. And second one is aromatase inhibitors, which includes letrozole and anastrozole. So obviously, you know the mechanism of action, but I'll give a short recap. What's the difference between the two groups? The basic difference is SERMs act for a long time. Half-life is almost 2 weeks. Where it comes down to aromatase inhibitors, it's just 2 days. So what happens? The basic mechanism is that to cut down the estrogen negative feedback to the hypothalamus, which the SERMs, clomiphene, does in a way that it blocks the estrogen receptors, and the action is prolonged. Whereas with aromatase inhibitors, it cut down the estrogen production by cutting down on the conversion of androgens to estrogens. Here, the feedback mechanism will be intact after some time because there's no receptor blockade and because of the short half-life. So basically, it means with clomiphene, the FSH window is prolonged, leading to multi-folliculogenesis, whereas with aromatase inhibitors, because the FSH levels come down, the window is shortened. So it will result only in monofolliculogenesis. This is the whole idea about area of action. Now, the recent guidelines can firmly say that letrozole should be the first-line drug, and they give the justification for that in like better ovulation, almost like 40 to 60% better live birth rate, and complication-wise, multiple pregnancy is much lower with letrozole, and there's insignificant side effects. So letrozole is the #1 drug. This is a strong statement. Now, the dosage schedule starts at 2.5 milligram, as everybody knows, from day 3 to 7. And in the next cycle, the ovulation doesn't happen. You can make an increment by 2.5 milligram, reaching up to 7.5 milligram. So this all started with the work of two stalwarts, Mithuvali and Professor Casper, way back, 25 years back. And they introduced the concept of an cancer drug, aromatase inhibitor, in the field of ovulation induction. But surprisingly, a very small oral abstract from the ASRM, which showed that this is an unfair study, which was never published in a peer-reviewed journal, which showed that there's an increased incidence of anomalies with letrozole. And the company, Novartis, recalled the drug for this purpose. And many countries, including India, banned the use of letrozole for ovulation induction. And when we began the practice, letrozole was banned for quite some time. Luckily, the very next year, the very big study from the same university by Tulandi et al. Showed conclusively that the congenital anomaly rate between clomiphene and letrozole was same, to the extent cardiac anomalies were more with the clomiphene group. But still, the ban was there. And finally, there came the best study, probably in reproductive medicine, by Richard Legros, a multi-center randomized controlled trial with 750 subjects, which showed conclusively that letrozole is superior to clomiphene in terms of ovulation rate, cumulative live birth rate, miscarriage rate is similar, and definitely much less multiple pregnancy. And there was no difference between letrozole and clomiphene in terms of congenital anomalies. Now, usually reticent Cochrane even came out with a statement that letrozole is much better than clomiphene in terms of pregnancy and live birth rate, and even better than the laparoscopic ovarian drilling, which is a surgical remedy for PCOD. Now, this beautiful network meta-analysis for the Novartis network meta-analysis is a recent statistical technique where you can compare different treatment modalities in a single study without any head-to-head comparison, combining the results from different RCTs. What they found was letrozole is just neck to neck with FSH in terms of ovulation. In terms of live birth rate, it's even better. And in terms of multiple pregnancy, it ranks much better just behind the metformin in the lower rung. See, less number of multiple pregnancy with letrozole. So it should be a wonder drug. Now, there are situations where letrozole is not working. What do you do? Go back. Ideally, the guidelines say that you should work up the patient in a better way so that you're not missing out any of these situations like hypothyroidism, hyperprolactinemia, late onset congenital adrenal hyperplasia, virilizing tumors, though very rare, and hypothalamic hypogonadism, and just obesity. So go back and check whether you have missed any of these. Like, so if it's a late onset congenital adrenal hyperplasia, you can have an elevated 17-hydroxyprogesterone. Androgen producing tumor, you might be able to pick clinically because they are very fast growing and the symptoms are very severe. Cushing syndrome, you might miss out because Cushing syndrome can be very similar to mild PCOS, but a 24-hour urinary free cortisol or a dexamethasone suppression test might help. But I think an endocrinologist must be employed in to do the further workup. Hyperprolactinemia and ubiquitous hypothyroidism. Don't miss out a hypothyroidism. So if you rule out all these, still the patient is resistant to letrozole. The resistance means their ovulation is not happening at 5 milligram 5 days. So what we can do? Studies say that one good study from the recent SRM journal says that if you step up the protocol, no, you can extend the letrozole regime for 7 days. If still not ovulating for 10 days, you can have better ovulation rate. Like the ovulation rate was 93%, and the cumulative clinical pregnancy was 32%, live birth rate is 22%, and with not a single case of ovarian hyperstimulation syndrome as we might expect. Now, from the original researchers, Mithuwali and Kasper tried a different regime. They gave 20 milligram letrozole on day 3 instead of the 5-day regime. And what they found was it is equally effective in terms of all the parameters like follicle number, estradiol level, endometrial thickness, everything was similar. I don't know why it was taken up. Maybe because the 20 milligram as a single dose might not be palatable. So there are other studies, very recent studies, which tried the same thing, 20 milligram, 25 milligram, day 1, day 3. They have found that the results were equal in terms of outcome, in terms of ovulation rate. So you may be able to try those things. Now, even more recently, people have tried the stair-step protocol. It's my favorite thing. You will see now what is the stair-step protocol. The upper line shows stair-step protocol, lower line the conventional way. Conventional way, what we used to do, we give 2.5 milligram per day for 5 days, and we check for folliculogenesis, and follicles not coming up. Progesterone levels are not rising to the 3 nanogram level. So we wait for a bleed. We give a program bleed with progesterone, and from the day 3 again start the letrozole incremental dose. This is the conventional way of incrementing the dose of letrozole. But in the stair-step protocol, you are giving the same 2.5 milligram. You check at day 14 and you see there are no follicles. You can straight away go for 5 milligram. And similar thing happens if it's not working with the 5 milligram, go for the 7.5 milligram. Here, we are not using the program bleed as the starting point for incrementing the dose of letrozole. There are many studies which have proven that with clomiphene or letrozole, there's no need to wait for a withdrawal bleed to start the ovulation induction. And what they found was the results were comparable in terms of pregnancy, live birth rate, everything. But the best thing was the time to ovulation was almost halved in the group of patients who went for the stair-step protocol. And the endometrial thickness was significantly better with the stair-step protocol. So it's going to stay. This stair-step protocol is compared to the conventional incremental program is much more effective and safe because there was no hyperstimulation. There were equal number of multiple pregnancies. Now, so we have come to say for sure conclusively that letrozole is better than clomiphene in terms of efficacy, means ovulation, clinical pregnancy, and live birth rate. What about the anomaly rate? It's comparable to clomiphene and more even compared to the babies born out of natural conception. So are we going to throw out clomiphene? The only indication which the recent guidelines say is some countries have still not accepted letrozole as a regime for ovulation induction, where it's an off-label one. There you can use clomiphene. Coming to the works by review by Roy Homburg, you can give clomiphene, but 150 should be the ceiling dose because with 150, nearly 90% of subjects will ovulate. Beyond that, there's no use, and no use in using the clomiphene for more than 6 cycles. And because nearly 3/4 of subjects ovulate with clomiphene, but hardly 1/4 will conceive. So there should be a problem with clomiphene. The problem can be with the peripheral anti-estrogenic effects of clomiphene because of the receptor blockade. It can have deleterious impact on the cervical mucus and at the endometrial level. Probably the high LH seen in the PCOS might be a different factor regarding the oocyte quality. So if you are bound to use clomiphene, use it along with metformin because clomiphene-metformin combination is much more effective than clomiphene. That's a strong statement, conclusively proven, but make sure you are monitoring the cycle with ultrasound because the incidence of multi-folliculogenesis and multiple pregnancy are very similar in clomiphene alone and clomiphene plus metformin cycles. So you have to do an ultrasound monitoring each and every cycle. So clomiphene is a better drug combined with clomiphene. It has a good ovulation rate, better clinical pregnancy rate, and less multiple pregnancy rate, and coming just below the letrozole run in the network meta-analysis. What about the other anastrozole and anastrozole, like how they perform? There's no difference between anastrozole and letrozole in terms of efficacy and complications, but there are very few studies which Cochrane could collect, and one of these studies say anastrozole is inferior to letrozole in terms of suppressing the estrogen levels. Now, what about the second term, tamoxifen? Tamoxifen is in comparison to clomiphene, supposedly effective according to the Cochrane in terms of live birth rate, miscarriage rate, and even the complication. But to me, I might use tamoxifen in a patient who repeatedly comes with thin endometrium in spite of letrozole. But I have my own doubt whether tamoxifen improves the pregnancy rate, live birth rate, in spite of the endometrial, better endometrial profile. That's my personal doubt. We can clarify this in discussion. So this picture will give you the whole detail. The arrows show the efficacy of the drug. Green shows, the color shows the comfort level and the risk. Green means better, red means bad. So letrozole has all the arrows pointing upwards. It's a most efficacious drug with 3 greens and 3 yellows and no red. So it definitely scores above the other drugs in terms of ovulation reduction. Now, this is a flow chart for how to treat a patient with polycystic ovarian syndrome. So it's very evident that letrozole is the first line drug. You can use clomiphene along with metformin in some specific situation which I mentioned earlier. But after due counseling, that there are better drugs like letrozole. And if they ovulate, how many cycles will take? They very specifically say that number of cycles depend on a shared decision-making basis. You talk to the patient, consider the age of the patient, availability of resources like IVF. If everything is fine, you can go ahead with few cycles. That depends whether it's 3, 4, 6 cycles, and then move on ahead. And if they are not ovulating with letrozole, what's the next one? It's gonadotropin, which Dr. Bave will be talking on, or laparoscopic ovarian drilling. Now, a word about unexplained infertility. In unexplained infertility, the recommendation is very strong that IUI should be combined with ovarian stimulation as the first line. So what about oral ovulagens alone? The empirical treatment with clomiphene. Clomiphene is the drug, chosen drug in the oral ovulation in unexplained infertility because it can give rise to multiple folliculogenesis. But what the studies found that there's no improvement in the time to live birth, and they can have more complications like multiple pregnancy with clomiphene and compared to expectant management. And the NNT number needed to treat is very high. You need to treat 76 additional subjects to get an additional pregnancy with clomiphene. So clomiphene citrate will result in 4 to 6% pregnancy rate if used alone in unexplained infertility. So do not offer oral ovulagens like clomiphene in unexplained infertility. Clomiphene can be used in combination with IUI. So to summarize, the first line therapy for ovulation induction in anovulation is letrozole. Clomiphene with metformin might be an alternative in cases where letrozole is not to be used, probably legally. Letrozole in alternative regime might be effective where the conventional 2.5 to 5 milligram 5-day dose is not working. Oral ovulagens like clomiphene alone might be superfluous in unexplained infertility. Thank you for your patient listening.
I request the chairpersons to initiate the discussion. Dr. Usha, Dr. Bhavya, and Dr. Jayakrishnan.
Thank you, Dr. Hari Kumar. That was a wonderful talk covering all the aspects of oral ovulogence. We would like to take some questions in the chat box. First of all, you told about the stair-step protocol. Can you enumerate how you will monitor the cycle in the stair-step protocol? Can you once again
Am I audible, Sin?
Yes.
Hello.
Yes, sir.
Yeah.
Yes, sir. Yes,
Hari,
sir.
please stop sharing. Hari, stop sharing.
Yeah. One second. Yeah. Meanwhile, can I talk?
Yes.
Yeah. Stair-step protocol. Actually, the follicle growth. Our main weapon is ultrasound. So you can look for a 10 mm follicle. Probably after 5 days after at the end of the letrozole treatment regime, 5 days after, you can look for a follicle. If no follicle of 10 mm is there, you can presume that the drug is not working at this dose, and you can go for the higher dose. And there's another ways to check for the progesterone, but you very well ultrasound will work.
Okay. So there are some more questions. Because of the shortage of time, I think we'll take it later. Thank you so much.
Yeah, sure.
Hari, can you stop sharing?
Yeah, sure. I'll try.
Thank you so much, sir, for that crisp and informative talk. And I thank the chairpersons also for chairing the session. So now that we know the agents, next we are up with the topic ovulation induction protocols. Now I request Dr. Reggie to introduce the chairperson and the speaker.
I would like to request Hari to stop sharing.
Yeah, I'm trying, man.
Then only I'll be able to share the.
Yeah, sure. Yeah, I've stopped.
Okay, thank you. So I would like to introduce the next chairpersons for the meeting. So what we have in our as experts is Dr. Sharad Devadas. Am I audible? I audible?
Yes, sir. Yes,
Okay,
yes,
Dr.
sir.
Sharath is the Director and Chief Consultant of Fertility First IVF Center. And he's a reproductive medicine consultant in Kottakkal, Alathur, and Tirur. He's Joint Secretary of Perinthalmanna Obstetrics Gynecology Society. And his main interest is in vitro IVF, male factor infertility, recurrent pregnancy loss, and sexual wellness. Welcome, Dr. Sharath. And I would like to welcome Dr. Amar Ramachandran. He's our cine star. He's a reproductive medicine consultant in Koili Reshmi Fertility Center in Kannur, former professor of Kannur Medical College. He has got an Imaging Science Award in 2012. He has got a number of national and international index journal publications and written a few chapters in undergraduate as well as postgraduate textbook. Welcome, Dr. Amar Ramachandran. And our third expert is none other than Dr. Shruti. Yeah, Dr. Shruti A.G. Shruti is from Kasargode Society, and she's a consultant in reproductive medicine as well as cosmetic gynecology. She's a member of IEG, ISAR, IFS, COGS, and FOXY, Vice President of Kasargode OBG Society, past Secretary of Kasargode OBG Society, and she's a Sexual Committee member, FOXY. Welcome you, Shruti, to this meeting. Over to you, chairpersons. I request Dr. Amar to introduce our speaker, Dr. Priya Bave. Amar, can you see the slides? Amar, can you do the honors? Amar?
Yes. Reggie, please introduce her. Okay.
I think Amar is not this thing. I would like to call upon Dr. Priya Bave, who is a senior consultant and IVF specialist at Benzal Hospital, Bhopal. She did her MBBS and MSOG from Gandhi Medical College. She's one of the first fellows from CMC Vellore, almost recipient of 10 gold medals and from President of India gold medal during MBBS and MD. She's an esteemed faculty in numerous national and international conferences, and she's a triathlete, and she's the Iron Lady. She was awarded Iron Lady, I think, last year or day after or the previous year. She's a TEDx speaker. She has got numerous papers and publications in various reputed journals. I would like to extend my thanks to Priya Bhave Madam for joining this webinar. Over to you, Priya Bhave Madam.
Managing Director of the IAGs.
Yes, Subhash. Subhash.
Thank you so much, Reggie. And I would like to thank Dr. Reggie, Dr. Subhash, and entire Kerala Obsgynae Society for inviting me. I think I'll just start sharing my screen. This is a topic which is like really very, very close to my heart. And invariably, I have been into teaching for a very long time now. And every time we have a new batch of fellows, a new batch of trainings, the thing they're most keen to learn about is tell us about the protocols. So the first question is, when are you going to teach us the protocols? What are the protocols? And at every conference, the moment you say the word protocol, there will be many, many people who are willing to listen to you. But how I look at it is that practically, I think we have to look at the principles rather than protocols. All the women that we see in our practice are very, very different from each other. Even if we end up seeing 10 women of PCOS, they are so different in their baseline characteristics, in their BMI, in their insulin resistance, in their response, that it is very, very difficult to classify them into very set protocols. So in all my protocol lectures, I always begin with the principles, because I feel that if you know the principles, the protocol has to be tailored according to the patient. And without the knowledge of the principles, protocols are meaningless. So for many, many years, for decades, we were following this classification of WHO ovulatory disorders, that is type 1, type 2, and type 3. All of us know that type 1 and type 2, that is hypo and PCOS, are the patients where we'll induce ovulation, and type 3 are the patients with ovarian failure where it is of no use. However, after many, many years, FIGO has now recently come up with a much more refined system of classification of anovulation. And all of us as practitioners have to know about it. It is called as the gain fit pi classification. So it follows a similar scheme, but I feel that it is little more detailed and little more practical, not only for us to remember, because unless we know the etiology, we will not be able to treat the patient. So what gain fit pi means is, type 1 is the hypothalamic causes. So they can be genetic, they can be autoimmune, iatrogenic or neoplastic. Type 2 are the pituitary, that is functional, infectious, and trauma. Type 3 are the ovarian, but the difference is that unlike the previous classification, PCOS is type 4. So now PCOS is not type 2 anymore, they are type 4. Essentially, whenever we talk about ovulation induction, the intent of this entire exercise has to be very clear to us. The intent of ovulation induction is to make somebody who is anovulatory ovulate. The intent of ovarian stimulation is to make a person who is either anovulatory or ovulatory produce more than one follicle. So I think with this background, throughout my presentation, I will only be talking about women who have anovulation. Practically, we will be talking about hypothalamic, that is type 1, type 2, and type 4. We will not be talking about ovarian failure, because ovarian ovulation induction is futile in these patients. Now we all have to realize that ovulation induction does not begin in the cycle or day 1. It actually starts in the gonadotrophin independent phase in the previous 3 months. And that is exactly why, like my previous speaker spoke about the importance of lifestyle change. If you see a patient with ovulatory dysfunction, say PCOS, and you give her a registron and you start with ovulation induction right away, probably you will not get a good result. You need to have a good milieu in the body in the previous 3 months. And that is why if she is overweight, correction of that, a proper exercise protocol, which the WHO guideline points out, it is very, very important. We have to stop looking at ovulation as a 14-day thing. It starts at birth, and there is a very important gonadotrophin independent phase of the previous 3 months, which is going to influence your results. Now, all of us for many, many years thought that recruitment can happen only in the follicular phase. But now we know that follicles can be rescued at any phase. And now practically all of us are using this random start protocols. We are using luteal phase stimulation. And over the last 4 years, this has become very, very commonplace. So what is happening is, for the very long time, we have lived with certain concepts of types of ovulation, that ovulation can be induced only in the follicular phase. All of that is changing very rapidly. Now, when it comes to ovulation induction, I always feel that it is much more challenging than ovarian stimulation. That is because it is like riding a horse which has a potential to go very fast, but you got to have the reins in your hands very, very tightly. That is where it is little different from ovarian stimulation, because your intent could be to have 10 follicles in IVF, but even if you have 15, you are fine. You are able to manage. But in ovulation induction, if you have 3 or 4 follicles, probably you would end up cancelling that cycle, because you don't want that patient to end up with a multiple pregnancy or an OHSS. So we have to remember certain 2 important concepts. First is the process of selection. Now, what is selection? Selection happens because from the cohort of the follicles that are recruitable, the antral follicles that we see in the 2nd or 3rd day of the cycle, all the follicles have FSH receptors, and they will start growing under the influence of FSH. But beyond a point, their growth profiles will diverge and one follicle will become dominant. And this is exactly what we want to replicate when we want to do ovulation induction. Suppose if we are able to recruit the follicles, we are able to make them grow, but we are not able to make one follicle diverge from the rest of the follicles and become a dominant follicle, we end up with all the complications. And I think the whole point of ovulation induction is to avoid OHSS and to avoid multiple pregnancy. So this is a concept we'll keep on coming back to even as we discuss the protocols. So the first concept is recruitment, and the second concept is selection. Selection involves divergence and dominance. So a particular group of follicles is recruited. Out of that, the growth profiles will diverge and one dominant follicle will be selected. So recruitment and selection. Now, what causes this FSH this follicular recruitment and selection is the phenomena of the FSH threshold and the window. This is beautifully brought out in this diagram. So we have to remember that FSH threshold is the concentration of FSH. And FSH window is the time for which this FSH is elevated. Now, the very fact that it's called a window is that it closes. So that means that anything that you give for ovulation induction has to keep the FSH above the threshold only for such time that you are able to get the divergence and the dominance, and then the FSH levels have to fall. This is exactly why when we give letrozole, when we give clomiphene, we give it for 5 days and then we stop, so that the endogenous FSH has time to rise and then it has time to drop. Now, this is exactly what we have to keep in mind when we are inducing with gonadotrophins also. Another very important thing is that in women with PCOS, the FSH threshold of every woman is different. So sometimes we are giving her FSH at 75 as the protocol would have us give, but we don't see any follicle getting selected. That is because the threshold is not broken for that particular woman. So usually what will happen is women who are more obese, women who have more insulin resistance will have a higher FSH threshold. Now, how to know this FSH threshold is very difficult. Unless you administer the drug, you will not know it. Another important theory is the 2-cell to gonadotrophin theory. And what it means is that theca cells are able to produce androgens. These androgens are aromatized by the granulosa cells into FSH. Now, what happens in PCOS is that there are a lot of theca cells, so there is a lot of androgen. So imagine a factory wherein, the input is clogging and the output has a limited capacity. So granulosa cells are not able to aromatize that much androgen, and that androgen accumulates, and this contributes to the resistance to FSH, the requirement of FSH. So this is something which is very, very important when it comes to the women with PCOS. We have already discussed about the FSH window, which is a duration. But in women with PCOS, we also have to remember a certain concentration, and this concept of LH window is a concentration. So LH above the ceiling will cause atresia of the follicles. LH below that, like how it happens in hypo, so in hypo, there's no endogenous LH. So if you stimulate this women with only FSH, you'll get beautiful follicles, but you'll never have any estrogen. So what will happen is she will ovulate, but she'll never conceive because there's not enough steroidogenesis because of the low LH. So what is that golden amount of LH? That is the LH threshold. That is, it has to be more than 1.2 units per liter and less than 5. So women with type 1 and type 2, that is hypothalamic and pituitary, we need to supplement LH. Women with high LH like PCOS, the reason for non-response could be the high LH levels. So, and last and very important is the role of AMH in recruitment and selection process. For some time when AMH just came in, we thought of it like an innocent bystander, which just tells us that how many follicles are present. But in nature, nothing is superfluous. So AMH is actually the gatekeeper which prevents the follicles from getting the FSH sensitivity. So higher the FSH in a woman, the more likely she is to be a non-responder, require higher durations and require higher doses of stimulation while we are doing the ovulation induction. So with this, I would like to also bring your attention to these two important concepts. For decades, we thought that it is the elevated estradiol which is the trigger for LH surge. Isn't it? All of us thought that the dominant follicle will keep on producing estradiol and above a particular threshold, there will be the LH rise. But now there is very, very convincing evidence which is coming up since the last 4 years. So this is a study which looked at the fact that elevated estradiol is not the trigger for pre-ovulatory LH. They looked at women who were given letrozole and they had very, very low serum estradiol levels, but all of them had endogenous LH rise and they ovulated. Then there was another article in Fertility Sterility, and what they said is that it is not the rise in estradiol, but there is a small increase in progesterone around the time of ovulation, which causes the trigger. So look at these two diagrams carefully. The first one is the current ovulation paradigm, which says that the moment estradiol rises, there is an LH surge. But this new concept says that around 12 hours before the LH surge, there is a small rise in progesterone. And this is actually the trigger. And this, I think, could be the game changer in the times to come. We will have more therapies which are based on this concept rather than the concept of looking at high estrogen, which is leading to the premature LH surge. So the intent of our ovulation induction is monofollicular growth. And what we are going to use is all these concepts. So what are these concepts? FSH threshold, which is a level. FSH window, which is the duration of time that this FSH is above the threshold. The LH threshold. And finally, the role of AMH. So before induction, of course, you have to have patent tubes. You have to have a good analysis. You need to have all the other hormones, thyroid and prolactin, tested. Now, always remember that this is the key. Using the proper dosages, using the proper drug is actually less important than lifestyle modification. In my own experience, any patient who is put on a lifestyle change will respond much better. And actually the quality of the oocytes that you get is going to be much better if you aim at lifestyle modification. There definitely that fear is always there that, you know, if I tell her to lose weight, she'll go to the next doctor. But then we want to be doctors who have a lot of patients, but we also want to have doctors whose patients succeed the first time they try, isn't it? So I personally feel that lifestyle modification is very, very important before we start with gonadotropins. So primarily we'll be focusing upon ovulation induction. We'll be not talking about ovarian stimulation. We'll be talking about hypo, and we'll be talking about PCOS. Now, there was a time when there was this single study by Roy Homburg which said that while the world uses clomiphene as the first line, gonadotropins also can be used as the first line, and actually the time to pregnancy is faster when you use gonadotrophins. Personally, I don't agree with this because of two reasons. One is that this was only one study which showed this. Subsequently, I have screened the literature and have never found a good study which compares gonadotrophins as first line with clomiphene or oral ovulagens. Also, I feel that the skill of the doctor also makes a very big difference. So if in very, very skillful hands, maybe this is the result. But when we are running large departments, when we have a lot of trainees with us, sometimes some ovulation induction can actually go wrong and the cycle needs to be cancelled. So I would always give oral ovulagens as the first line. Ovulation rates are very good, but the multiple pregnancy rates are also something that we have to reckon with. They are actually very, very low with letrozole. So I would not use it as the first. So the principle is again that you raise the FSH level above the threshold. You keep it raised long enough just to rescue only one follicle. You don't want to rescue more than 2 follicles. So in ovulation induction, if you actually get 3 follicles, this is an induction which is not done correctly. So your intent is 1, 2 is okay, but 3 is actually not a good idea when you are inducing. So this titration that the FSH has to rise above the threshold, stay above the threshold and come down, that is what requires a lot of practice and experience. So you absolutely have to monitor with USG. I just love the slide that my previous speaker has shown, wherein he shows that the number of ultrasounds that you require with gonadotrophins is a lot, and that is the flip side. Now, disadvantages are that you will definitely have multiple pregnancies. You will have 1 to 2% OHSS rate. So we are limiting it to only resistant cases. We are not using it as the first line. Now, there is so much discussion about which gonadotrophin to choose. Every day in the market, there'll be a new gonadotrophin, and practically for all practical purposes, it doesn't matter. There are many people who will tell you that, if the day 2 LH is this much, then you use recombinant FSH. If she's PCOS and obese, then use recombinant or highly purified FSH. But practically, in my own experience, I have been using HMG for ovulation induction. It actually doesn't matter. But yes, if it is a patient with hypo, you need to have a combination of LH and FSH, whether you use HMG or you use the recombinant pergoveris, that is up to your choice. Now, I thought I should put this slide because in many of my trainees, they have a lot of confusion. What is HMG? What is HPHMG? What is urinary FSH? And what is highly purified urinary FSH? So HMG is something which is derived from the urine of postmenopausal women. It contains equal activity of FSH as well as LH. But it contains only 5% activity of HMG. 95% is the urinary proteins. So the flip side of HMG is that if you try to give it subcutaneous, because of these urinary proteins, the patient will have some reactions, will have some pain and swelling. So advantage of HMG is that it is cost effective, but it has got a lot of urinary proteins. So when you run it through gel electrophoresis and you remove these urinary proteins and you make them less than 5%, it is highly purified HMG. Now, if somebody says that I don't want this LH activity, this HPHMG is run through antibodies to LH. So what happens is all the LH gets absorbed to the antibodies to LH, and all that you have remaining is the urinary FSH. And urinary FSH will have less than 0.7 IU of LH activity. If you further refine it, you get highly purified urinary FSH, which has got very, very little amount of LH activity, but the cost factor will go up. But the moment you see highly purified, you can use this subcutaneous. So the patient need not get intramuscular. She is okay to get a subcutaneous injection. So this is about HMG. It cannot be given subcutaneous. HPHMG can be given subcutaneous. IU is basically the biological activity, but nowadays we get recombinant injections which are actually filled by mass. So the biological activity is not needed. You can get more purified ones which are filled by mass when you use the recombinant preparations. So just to compare, cost effective, definitely urinary. Recombinant, the flexibility is much more. So you can use 37.5, you can use 50, you can use 75, you can use 66.5. All of this because recombinant comes as a pen. So it's very convenient. The patient carries the pen home. You tell her that, okay, you have to take 37.5 daily. It is not possible so nicely with urinary, but it is possible with the recombinant. So practically, in the effect, if you see the Cochrane review, this is the Cochrane review. It's a little old review. It's not been revised yet, 2015. But if you see the live birth rate per woman, so whenever you're seeing a Cochrane review, the best way is just go to the summary of findings table. So summary of finding table will be something like this. What it will tell you is in very, very simple words. We are all confused about relative risk, confidence interval. None of that knowledge is needed when you're reading a Cochrane review anymore. So look what it tells you. It tells you that live birth rate per woman when you give with urinary gonadotropin is 157. Okay. When you compare it with RFSH, the live birth rate is 190 per 1000, but the range is 130 to 279. That means if you compare 157 to 130 to 279, there is actually no difference between the live birth rates, right? Same way, multiple pregnancy rate, 30 per 1000 in urinary, but in RFSH, 14 to 48. So again, 14 to 48 includes 30. So practically in all of these, whether it is miscarriage rate, incidence of OHSS, practically there is no difference. So I believe that don't get into titrating and how much LH and how much FSH. Practically, it's a fruitless exercise. The evidence would also have us do the same. Now, finally, when I have very less time, I come to my topic, which is the protocols. So protocols is step up protocol, step down, and the protocol that all of us like to use, that is the CC-FSH or letrozole with combination protocols. Now, conventional regime, practically, I have never used in my life. So in conventional regime, they start with 150, they give it for 7 days, and then the increments are made of 75 IU every 7 days. But practically, I have never actually used it. I have never seen it being used, even when I was training. So practically, I think all of us, what we follow is the low dose step-up regime. The reason being that I think the Indian women are actually smaller. And especially in central India, we don't see that much obesity and we don't see that much insulin resistance. So most of my patients will actually ovulate with a lower dose. They will actually ovulate with 50 or even 37.5 because we see a lot of lean PCOS where we are. But the problem with low dose step-up protocol is that you actually have to be very, very patient. In my experience, most of the times, the doctors lose patience before the patient does. So in low dose step-up protocol, it's very normal to have no growth of follicles for 7 days, for 14 days. So we actually have to set the expectations right first for ourselves. It is a low dose step-up protocol. So we are slowly trying to find the FSH threshold of the patient carefully. We are going from below up. So you have to start with 37.5 or 50 or 75. In my practice, I'll always start with 50 or 75. Very lean PCOS, I even start with 37.5. Now, if the follicle has not grown for 7 to 14 days, only then we'll increase the dose, and the dose increments have to be 37.5 or 50, not more than that. So the longest that we have stimulated is 7 weeks, and we got a single follicle. So if you want to stimulate, please make the patient mentally prepared that this gonadotropin injection of 300 IU, we are giving it to you. You might need 3 or 4 such pens, because the patients will start comparing that lady is getting IVF injections and she is already ready in 10 days and she already had a pickup and she had embryos and I'm coming for last 1 month. So set your expectations and the patient's expectations correctly. Only then you will have the good result with the step-up protocol. Otherwise, what will happen is you keep on increasing the dose very fast, and then you have to call up your IVF colleague because you have too many follicles and all of them are growing. So 37.5 to 75 IU, scan on day 7. If there is no follicle more than 10 mm, then increase the dose by 37.5 or 50% of whatever dose you have started with. Again, give it for 6 to 7 days. Don't be in a rush. Don't keep on calling patient every day if you don't see a dominant follicle. Overnight from 10 millimeter, it will not become 18 millimeter. Now, once the dominant, because it is a low dose protocol, you will usually not see a premature LH surge. Premature LH surge you will see when you start trying to give gonadotropins to a patient with low AMH. These patients will have a surge even at 14 mm follicle size. In PCOS, actually, they will not have a surge until the follicle becomes 16, 17 mm. And after 14 mm, definitely you have to monitor more frequently. What about the step down regime? Step down regime, when I was a beginner, I tried to use it. But every time that I have used the step down regime, I have actually burnt my fingers, because theoretically, it seems correct that you start with a high dose. The moment you see a dominant follicle emerging, you reduce the dose. You say that that follicle already has FSH receptors, and even when you reduce the FSH dose, that follicle will still continue growing. But practically, in my experience, when you give 150, all of the recruited cohort of the antral follicles starts growing. And then what happens is, when you reduce the dose, you may have one dominant follicle, but you have a lot of intermediate follicles. And all of these intermediate follicles are contributing to the OHSS risk of the patient. So while you may have one beautiful 18 mm, you also have 12, 11, 11, 13, and all of them can also potentially ovulate, plus they will contribute to the OHSS risk. So practically, I don't use the step up, step down protocol in my own practice. And I feel that it is much more risky to use, at least in our Indian patient subset. If you see a comparison in the evidence, practically they also say that hyperstimulation rate is much higher in step down cycles. They have mentioned it as 11%, but I think in real world it will be higher. Now, the regime which is my favorite is the clomiphene and gonadotropin combination regime. We do give it more often because it reduces the cost to the patient. And many patients will not ovulate with letrozole alone, but the letrozole-induced rise in FSH, when you augment it with the exogenous FSH, you do get a good physiological rise, and the cycle is much more in control. Because what happens is, because of letrozole, that initial selection of the dominant follicle has already occurred, although it's not seen to you yet. So most of the cycles in these CC letrozole cycles will have either one or it will have two follicles. So another is that you started simultaneously. Some people give a dose on day 2, alternate day, and then they give it daily. So this is up to you. This is your preference. The trigger criteria remain the same. You don't wait too much. You give a trigger at 18 mm. And advantage is that, of course, the cost and more incidence of monofollicular cycles compared to gonadotrophins alone. Now, monitoring has to be very, very appropriate. Very important is the trigger. I see very often that patients are stimulated beautifully outside and they have been given a luprite trigger. Now, remember that if you give a luprite trigger, you are causing a massive luteolysis, and your pregnancy rates are going to be very, very poor. So according to me, practically, there is no role of a luprite trigger in ovulation induction cycles or IUI cycles. Luprite trigger has a role only and only in IVF cycles where you want to freeze all. Simply because the moment you give luprite, you are going to cause luteolysis. And in all gonadotropin cycles, anyways, is going to be a luteal phase defect. Also, in one subset where you never use GnRH agonist triggers is hypo-hypo, whether it is IVF or IUI. And finally, you've made a beautiful follicle, you have given a good trigger. Remember to support the luteal phase, because if you see this meta-analysis, when you give gonadotrophins, if you give luteal support, the pregnancy rates are much, much higher compared to no luteal support. So every gonadotrophin cycle, luteal support absolutely has to be there. There is no two ways about it. Multifetal gestation is a complication of ovulation induction. If you see twins, don't be happy. If you see triplets, don't be happy. It's a complication. It should never have happened. And finally, hypo-hypo is one subset of patient where this is going to be very, very gratifying. The pregnancy rates are as high as 25% per cycle. So give FSH as well as LH, always trigger with HCG and give a good luteal support, and you'll get a good results in hypo-hypo. So please remember, it's not about the protocols, it's about the principles. Protocols have to be different for every patient. They have to be tailor-made, but the concepts and the principles remain the same. And if you have managed to have a monofollicular development in a gonadotrophin cycle, even if you take 6 weeks, I think you've done a good job. So thank you so much. And thank you so much for this opportunity. I really enjoyed being here.
Thank you so much, ma'am, for that elaborate talk. I would ask the experts to give their opinions.
Thank you so much, ma'am. This is Dr. Amar. It was really elaborate. You've touched upon the right from the physiological aspects to the ovulation induction protocols. Thank you so much. I think nobody will have any doubts on this because it was
Oh, I'm so
crystal
sorry.
clear.
I think I've exceeded my time.
No, ma'am, we have the finished contact. So as there are no questions at present, so we'll go on with the webinar, the last session, that is the panel. And thank you, Priya Madam, and all the expert chairpersons for the session. So coming to the last session for the day, we have an interesting interactive panel on topic case scenarios in ovulation induction. I request Dr. Reggie to officially introduce our moderator to the gathering. And Reggie sir, next slide, please.
Yeah, coming 1 second. Yeah. Good evening, everybody. I would like to welcome our Professor Dr. Neela Malhotra, who has already been introduced by Kunjumoideen sir. She is currently the Professor and Head of the Department of All India Institute of Medical Sciences, New Delhi. He heads WHO Collaborative Center for Research in Human Reproduction, President-elect Indian Fertility Society, and Senior Vice President of IFS 2022-2024. She's got a number of fellowships, awards. She's a very renowned national and international speaker. Her interest is particularly on endometriosis, fertility preservation, ovarian tissue cryopreservation, and all. And she has got a number of lot of publications to her credit. Welcome, Nina, madam. Shall we, ma'am? Shall we introduce the?
Yes, Reggie, it'll be nice if you introduce the moderators. I know them by names, but I don't know their affiliation. I'll be happy if you could take over on their introduction.
Yes, ma'am. Yes, ma'am.
We have a vibrant team of panelists. To begin with, Dr. Priya. She is in charge of Reproductive Medicine Unit in Government Medical College, Calicut, since past 9 years. And she has published numerous papers in national and international journals.
Welcome, Dr. Raghavendra Prasad. He's actually he's from Kasargode Society. He's a well-known figure in India, in Kerala as well as India. He's a consultant director and infertility specialist of fetal and maternal unit of Sunrise Hospital, Kanjangada. He has so many achievements and awards to his credit. He has participated in various conferences in AKCOG, ISAR, IFS, all those conferences. He is very much interested in research and he has got a number of publications too. He has held, he was a past president of Kasargode OBGYN Society and currently a member of Sexual Medicine Committee, FOXY, as well as South Zone Coordinator for Public Awareness Committee of FOXY. Welcome, Dr. Raghavendra Prasad.
Next panelist, we have Dr. Ashwati Kumaran. She is the consultant reproductive medicine at STEMIMS Protocol. She has been a contributor to ESHRE guidelines 2019 and 20, and also an RCOG associate. And she has been an invited faculty at numerous conferences. Welcome to you, Dr. Ashwati.
So I have the opportunity to welcome Dr. Soma Vishnu, who is a consultant obstetrics and gynecology consultant in obstetrics and gynecology in Vinayaga Hospital, Wayanad, Kerala. And she's from Wayanad Society. She's the founder treasurer of Wayanad Obstetrics and Gynecology Society, member of Perinthalmanna Committee, very active in Kfog activities, very active national conferences also. She's an associate editor of Kfog Journal. She's a district coordinator for EMOCALS, executive member of SFM chapter North Kerala, organizing secretary of first All Kerala Perinatology conferences, invited faculty of national and international conferences. Welcome you, Suma.
Thank you, sir.
Next, we have Dr. Satya Krishnan. She's a senior consultant at NK IVF Center, Calicut, and she's a review board member of International Journal of Infertility and Fetal Medicine since 2011. And she has authored chapters in textbook of ART by Kamini Rao across the years. Welcome to you, madam.
Thank you. Thank you.
I would like to welcome Dr. Saumya. Soumya Nair is a consultant gynecologist and infertility specialist and laparoscopic surgeon from CIMAR Hospitals, Edapal Hospitals Private Limited in Edapal. She had 10 years of experience in obstetric gynecology and especially in infertility and laparoscopy. She's a teaching faculty and coordinator for DNB and FNB candidates in Edapal Hospitals Private Limited. She's also a visiting consultant to Manu Hospital, Malabar Hospital, Relief Hospital, as well as Cooperative Hospital, Malappuram. Welcome you, Soumya, to this webinar panel.
Last but not the least, we have Dr. Rajiv. She's a consultant and IVF specialist at ARMC Hospital, Perinthalmanna, and has been an invited faculty in numerous state and national conferences. Welcome to you, Dr. Rajiv. Over to you, Neena, madam.
I request the panelists to switch on the mute button when you are not answering. Over to you, Neena, madam. Neena, madam, are you here?
Yeah, can I share my screen? Can I be allowed to share my screen?
Yes, ma'am.
I know I'm so happy that the two lectures are fantastic by the previous speakers and they've almost done the job. So we'll just go straight on the panel. And I know I have a galaxy of stars on this panel. I hope I have named everybody and spelled everybody right. Thank you so much for introducing them. So I think we'll just go to, I know the stage is all set. We know what is ovulation induction and we know what is ovarian stimulation. So Priya has already clearly, when they're not ovulating, we give them agents, but then be women who will actually be ovulating, yet we need to give them a push. And these are, so I just got really case scenarios, which you see in common day practice. And I want to say that as we have already understood, when the patient comes, we know we're giving ovulation induction. We may even join it with the IU. I just thought to get you this background because we have a lot of postgraduates and some young clinicians where I want to say, yes, you definitely need a semen analysis, but do you need to do a tubal patency? Do you need to do ovarian reserves? I think is again a physician choice and we'll take it later. So let's come on to the first three case scenarios are basically PCOS. That means they're anovulatory women. And I've got all the shades of PCOS, the type A, the type D, and the like. So I just thought I'll tell people briefly that we have a lot of phenotypes of PCOS for anovulatory, but we essentially know that by all the consensus, the A PCOS Rotterdam, we know A, B, C, D. A is the most severe form and D is the mildest form. I'm not going to repeat that, but I thought I'll just bring this to bring up the background. So any of the panelists can take it. Just bring, this is a 30-year-old lady, Mrs. X, who's primary infertility for 3 years. She's a known PCOS, phenotype A. So she's a typical, severe variant. She also has a class 1 obesity. She has insulin resistance. And when she came to us, she basically had 3 cycles of ovulation induction done on clomiphene. When we really got the records staggered, put around, there were 100 milligram of clomiphene she had taken, but she did not. She was ovulating, not sure, but she did not have pregnancy. So on the history, typical of PCOS, prolonged cycles, average flow, she had anovulatory response, BMI certainly 32.2, FG score was 8. You can see there is a chaotic kind of, pattern there. LH was also on the higher side, AMH is on the higher side, and put it in short, her insulin was also high. The free androgen index was also on the higher side. So she's typically a type A or a class of phenotype A. So we planned that we should do something on her. So I would request any of the panelists that what would you be your take on this lady who has actually tried and has come from a unit outside and is consulting you, any one of you, what would be your take on this kind of a background of a patient? Raheen, are you there? You can take this.
Madam.
Yes, ma'am. Good evening.
Type A, and she's having insulin resistance, and her BMI is 32. So first we want to first I will advise her to life.
Can you be a little louder? You're a little far from your mouth. Yeah. Can you be a little louder?
Can I? Is it audible, madam?
To me, not. What about others?
Not very clear.
Audible. Okay, then fine.
So, madam, she's a case of PCOS phenotype type A, and her BMI is more, that is 32.2, and her LH is on the higher side. And first of all, I will advise her to modify her lifestyle, diet and exercise. That will give her more. The insulin resistance will be decreased, and she will ovulate, and that will be ideal first I will go to. Then I will say start with the letrozole ovulation induction.
Okay, anybody wants, do you think her investigations are complete? Should we sort of weight loss we're advising? Should we do anything else? Or you're happy with just this investigation? Should you offer her something else?
Her thyroid needs to be checked.
Yeah, great. Thyroid needs to be checked. Anything else besides the
The
thyroid?
male factor has to be evaluated, ma'am.
Great. Even the lipid profile is missing. Anything else?
The male factor to be evaluated, ma'am.
Yes, a male factor to be evaluated. Anything else?
Glucose tolerance.
Glucose, absolutely. We need to do a OGTT and also we need to do an HbA1c. So I just wanted to tell you that this is what we got from the patient and we really wanted to have a complete picture. We don't need to do any investigation, but yes, triglycerides, the lipid profile, sugars, and also the thyroid. Anyway, they all were within normal levels. There was nothing abnormal. So I've already asked that how will you proceed further? And thank you so much. You've all added that we need to investigate a little more. Now, role in lifestyle, very nicely, Raina, you said, do you think in this patient you have any place of putting her on any insulin sensitizer, considering that she's 32.2 kilogram per meter square? She's not had an ovulatory response to CC. That means basically she was CC resistant variant. Even if she was not CC resistant, do you think we still need to give her some insulin sensitizers? Anybody here?
Yes, she not responding to the clomiphene, then adding metformin might be beneficial because it's going to reduce the androgen levels.
Yes.
So she may respond by adding metformin to clomiphene. Yeah. And I would prefer to give metformin for maybe 1 to 2 months before giving the next ovulation induction. Yeah.
Yes, absolutely right. Thank you so much. I think we gave a lifestyle, but we did add her metformin. We started her once daily and we stepped up to 850 milligram. That was the initial dose because of the side effects. And, the first line is letrozole. So she got letrozole for 5 days. And then we saw the dominant follicle and this is how she responded. So I just want to share that metformin did help us because when she had 3 cycles of anovulation on CC of 100 milligram, we felt it's better to start her with letrozole rather than go back with metformin. And this was given for at least, we gave her for 10 to 12 weeks of metformin and lifestyle because she did not do very well on weight loss. But yes, she just improved on her ovulation, certainly. So this is the way we saw her and this is where we progressed. So just to recap, as Priya's already said, and earlier also Dr. Ramakrishnan had said, lifestyle is the first line and the first line for pharmacology is letrozole. But in obese, you should also consider adding, metformin and letrozole. Just to tell, she did not have a tubal evaluation. Do you think we should have done a tubal evaluation for her at that point in time? CV
Yes,
analysis we did.
we should have done a tubal evaluation.
I think she has not ovulated, right? So maybe we can wait till she ovulates and 1 to 2 cycles where she ovulates and she does not conceive, then at that point of time, we can do the tubal patency.
Yeah, that's what is the beauty of a panel discussion with everybody giving. So I think decision on tubal testing is individualized. So you know that she's not ovulated. So I think it was a good idea to wait, because you give her lifestyle, you let her. In fact, interestingly, you will not be surprised. All of you have experienced. A lot of our patients, while they are losing weight on metformin, also they conceive. We don't even need to give them letrozole. Of course, yes, rightly said, we could wait for a tubal testing, but there'll be somebody who said, no, let me do it because it'll be an anxious couple. So I think these are all individual decisions where there are no guidelines, but I would also hold back tubal testing. So basically, ovulation with letrozole, I think it's very important that we do a baseline scan. We get an idea, even though she's a PCOS, her previous history is important. And this is exactly how we all give. I don't need to reiterate, which has also been told. Now, let's come on to another PCOS. That was simple. She's 32-year-old Mrs. X. She has infertility of 5 years. She's also a known PCOS. But this one is a type D. She's a milder version, right? She's anovulatory, but does not have hirsutism. FG score is okay. She also had failed ovulation reduction with CC. And if you look at it, her cycles were delayed. She had an anovulatory response, but interestingly, she's not an obese one. BMI is on the side of 24.1. We got her, hormone analysis done. Semen was normal. And this lady had got her HSG also done. I didn't get this here, but we had planned that let's look at it. The plan was to move further with ovulation induction because she was anovulatory. What do you think would be your take as compared to the previous phenotype A versus this one, who's a milder version? Do you think we'll go the same way, or should we change something in her?
Her BMI is quite normal, madam. So
Yes.
probably the lifestyle modification may not come into her. Diet modifications might help in her thing, and start directly with probably ovulation induction with letrozole.
Great, absolutely right. I think some diet modifications, maybe exercise should always be offered, even though they may not be obese, but somewhere we know that there's a place of exercise in maintaining their, BMIs and giving them quality of, improved ovulation. So, what we did, we started out with 2.5, as rightly said by Dr. Raghavendra. And when we did this, we gave her for 5 days. And when we did on day 10, she did not show any response to 2.5 milligram. You can see how small. There was not a single dominant follicle. And at this time, her endometrium was also 3 millimeters. It's not unusual, but we do get these surprises. We are hoping that she will respond, if not to clomiphene, this time to letrozole, but she didn't. So what is your take? Anybody here, or Dr. Raghavendra, do you think you want to continue her like this because she's already got 5 days of letrozole? Do you want to wait?
I mean, we can add another 5 milligrams and give it for another 5 days.
Okay.
And probably do a follicular scan again after a gap of 4 days.
Okay.
Or the other option, I mean, probably you can start HMG also if required.
I think these type of patients with a very thin endometrium, they have like a basal hyperandrogenism, which is causing the thin endometrium. So probably like gonadotropins along with letrozole might help better than letrozole alone.
This patient actually, because she has not at all responded to clomiphene, I would have started her at 5 mg directly. And since she has not responded to 2.5 mg presently, and her ultrasound shows just baseline, she can be directly started on letrozole 5 mg for another 5 days and followed up.
Brilliant. I think most of you are on the same ground that we can go ahead in the same cycle, right? So that means I'll just move my slides. So this is obviously clear that this one has not shown a response. We can probably call it like clomiphene resistant. Is she letrozole resistant also? So you all have clearly said that we could build up and what we call as a stair-step protocol where we could go up higher. That way we'll just say, so that means instead of 2.5, you could go far. Do you think if she does not respond to 5, you can go further? Because there can be a surprise in her. She may not respond to 5 also. Or you're happy with 5 and call it quit, or you would like to, anybody would like to go on further with this?
You can try 7.5 also.
Okay. So you would give 5 for 5 days and call her after 4 days, and then 7.5 again for 5 days or lesser days or more days?
7.5 for 5 days initially.
Yes, 7.5. So that's the beauty. That means in this cycle only you can salvage. What if she did not respond to all of this also? Because, or the patient says, I don't want to go. I mean, many times patients say, no, I'm tired. You're calling me 5 days, then you call me, it's always 14th day, you're starting me another one. And then you call me and it's already, because you need to counsel, isn't it? Before you really start jumping and saying, we'll add you another 5 days, another 5 days. What if the patient declines? She says, no, I don't want this kind of a long system. Can we give her something else?
I generally give my patients an option of either going in for 2 or 3 shots of gonadotropins and seeing if they are responding, or give them maybe 5 to 10 days of a combination of both or only orals, and then wait for a delayed ovulation response and seeing whether the follicle and the lining comes up, and a luteal phase support if she ovulates, or a withdrawal bleed if she doesn't.
That's nice.
Try that extended protocol, madam. You can give it for 7 days or maybe 10 days and then call her back.
Great. I think everybody's coming up with all the brilliant ideas. So would you like to do the HMG in this cycle only, like we give letrozole extended, or you would say, let's do in a fresh cycle, or what would be the take? I mean, anybody, because all of us have experiences.
Have a discussion with the patient, madam, what they would prefer. Would they like to, many people would resist the idea of taking injections right in the beginning. So we give them an option and see whether we can wait for a detailed ovulation response in the same cycle, giving them a withdrawal bleed, and then giving a fresh cycle with maybe injections when they are more accepting to it. Or there is no harm if the patient is willing to try to give 2 or 3 shots of injections and seeing if they are responding.
It depends upon how the patient is taking it.
Absolutely right. I think the patient has to be prioritized, and I think she has to be counseled. So in such scenarios, which is not usual, we have options of giving a stair step, We can do an extended letrozole regime, as has been talked by most of you, or alternatively, we can do a sequential gonadotropin. All of you will get 100 on 100. Brilliant. I think it's truly a very, very brilliant panelist that we have. So just to say what are extended letrozole and sequential. Extended letrozole is when we give 5 to 7.5 milligrams for 10 days. That means she did not respond. We could give follicle monitoring. Next, go for another 5 days, either with the same dose of 5 or maybe escalate to 7.5. In these cases, we do a TVS anytime 2 to 4 days after the last dose. That means you finish, but don't call her immediately. Give her at least a gap of 3-4 days. And as usual, when we find a dominant follicle with a good, only then we trigger and then offer them timed intercourse. That is called extended letrozole, which you all have said. The other thing is a stair step, which Dr. Aghaveda said that I would like to continue in the same cycle, go on. But I think when we do a stair step protocol, you have to be very mindful. Your patient has to be talked. Look, this is going to be a long cycle. You'll have to keep coming. So that is very important. And I think, as Soumya said, that letrozole, if she doesn't respond, I could wash it out, give her a withdrawal, and probably go on with addition of even HMG, which is like adding gonadotropins maybe after. But this should happen in the same or the next, again, depends on your choices, your experience. So I think all of the options are possible. But I would just say that in this scenario, what we did, we proceeded with the stair step. And we gave 5 milligrams instead of 2.5 for 5 days. There was no dominant follicle. And then we titrated or increased, escalated the dose to 7.5. We got a dominant follicle only after the 7.5. So probably this woman actually was only responding to 7.5. When we got a dominant follicle, we continued to monitor her. And imagine she took up to 26 days to reach to a dominant follicle. So, there can be some challenges, something similar to what we do a chronic step-up low-dose gonadotropin therapy that we do where we counsel. But this patient was very, very keen to go ahead, and she went ahead and we had an ovulation. So just to put it in short here, that when you have a kind of letrozole resistance, as we put it, that means the definition of letrozole resistance is somebody who fails to ovulate with 5 milligram doses. That's what is described. And the only way you could do it in the same cycle is only stair step. If you want to do an extended or you want to add gonadotropins, it's advisable to go into the next cycle. The advantages that you salvage the same cycle, you can have it without a risk of ovulations. These are the two advantages. So I think it has been mindfully thought and discussed with the patient. Now let's go on to the stair-step protocols I want to share. There was some studies where there was a comparison of stair-step of letrozole with clomiphene in PCOS patients. They found that using the stair-step protocol showed better results as compared to clomiphene only. And it was so these are two studies where they compared stair-step letrozole versus stair-step clomiphene, which we give escalating slowly in the same cycle, and they both proved to be efficacious. So let's come on to quickly to another scenario of PCOS, because this is the most common group we get. Now, this one is a patient who's 28-year-old. She's again type A, but this time she has frank hirsutism and irregular cycles again. She had also got, a background. Somehow, these are all real scenarios. And when I look back, all the three had taken CC in the past. A lean one, FG score was high. Our free androgen index was also on the higher side, but AMH is also on the higher side. Now, here lies a little difficult patient. What do you think would be the challenges in this patient? She's certainly hyperandrogenic, but not obese. Where the earlier one was obese, the earlier one was average weight. Anybody, do you foresee any challenges in her?
Ma'am, the main challenge will be she may not again respond to the ovulation induction which we give.
Yes.
So before giving the ovulation induction, I would like to give a suppression with OCPs for 3 months and then give an ovulation induction in this case.
Okay, your thought is, how would suppression help? What do you think what suppression would do?
It may reduce her resistance. It may improve her AMH.
Okay. Anybody else? Or is happy to go like this? All agree for this.
I would go directly with letrozole with the HMG and plan the treatment cycle. Or just try with letrozole first. I would try with letrozole first because her BMI is quite normal. Only thing, she's got hirsutism and she's got PCO. So probably letrozole, if it does not work, along with letrozole, I would try HMG also.
Great. Just want to share, I didn't get a slide here for positive term. Actually, there's a lot of data which says that giving OC pills in patients who have got high androgens or AMH high does not actually help. You're procrastinating because that will be during that time when you're giving an OC pill, and that effect doesn't carry on in the cycle which you're stimulating. So the idea that we really grew up and we learned in the previous years is now changing. You should go straight on with, head on with this. So I will just share, we started her from day 2 to day 6. I don't know, we started at 2.5. I think this was one of my postgraduates who had done this. But what we got was, we did get a dominant follicle, mind you, on day 10, but her lining was very thin, 3.9 millimeters. Is it normal or it's abnormal, unexpected, expected?
It is expected because the androgen levels is HER2.
Yeah.
So our androgen levels would be high, so it's quite expected.
Yes. Would you be happy to carry on, cancel her, do something for her ET, or you can do something here?
Actually, with further cycles of ovulation induction, this endometrium might come up. I would also like to counsel her for exercising, which would help in reducing the androgen levels, even though her BMI is normal.
Yeah. Anybody else? Anything else? This
Ruling out
scenario comes
diabetes
very often.
mellitus is very important. Ruling out diabetes mellitus and maybe adding an insulin sensitizer along with letrozole also might help in the picture, and also adding adjuvants that might improve the uterine vascularity and improve the endometrial lining, and response might also help it.
Okay, I think Sanjana is raising a hand. Sanjana, what you please, you can go ahead. You have a question, anything? Yeah.
She's day 12. She's day 12, 16 mm follicle. I think we can wait for some more days.
For some more days, madam.
And see if her endometrium is going to improve.
So, do you think, Raghvendra, you would wait for the lining to come up to at least 6 or 6.5? And what will be your limit? Would you wait till 22, 23? Because we don't.
I will wait till 20. I would prefer to wait till 20.
Okay, so you would
see
still
how the
wait.
endometrial response is.
That means we can call a day back on day 14. I think all these are possible, combination permutations we all do. Absolutely right. We do all these because we know thin endometrium is per se on because of the hyperandrogenic state. So basically, I want to get you this treatment is that we do see thin endometrium, particularly in PCOS. Not that they are hyperplastic endometrium also, particularly the ones who are. So would anybody think, I think somebody also said adjuvants. I want to hear, do you all give adjuvants to such cycles in the hope maybe adding a small dose of estradiol help, or you feel no, that will not help?
No, estradiol, I do not suggest estradiol as an adjuvant, madam. Estradiol, we will think of in such a scenario where the lining response, where the follicular response and the endometrial response is poor. If we add estradiol, surely the lining might come up, but the follicle may not go ahead.
Yes, absolutely right.
So the thing is, we should not start estrogen unnecessarily, but doing something like maybe adding antioxidants, or maybe asking her to exercise, something that improves the uterine perfusion, maybe adding arginine might help her. And with the follicular response, the endogenous estrogen will build up the endometrium.
Okay. And suppose we wash out and we feel no, would you think the same protocol would be used? Because we are looking at something where we would also get a thin endometrium next time. If we talk to the patient, she says, no, doctor, give me another cycle. Would you change your stimulation protocol for her?
Yes, gonadotropin stimulation might work better for her.
Yes.
I may try adding dexamethasone along with the letrozole. Like during the follicular phase, I might add a low dose of dexamethasone. So that might reducing the androgen level.
I thought we all have forgotten dexamethasone. We used it many, many years back, right? In the CC resistant
cases. Some patients are still responding, madam.
Yes, absolutely right.
Yes, madam. And we may have to revisit the diagnosis to rule out any other causes for excessive testosterone production, which we are actually overlooking, thinking that it is PCOS. And
I would also say, should also think for other causes, because a lot of time, I don't know about Kerala, but in North India, we still get genital tuberculosis. We do get thin endometrium. This lady may have had a past history of COX, and we are looking at hyperandrogenism, and this is really what happens in most of our scenarios. So we should also think like that. Anyway, so what we did is I'm just sharing you, this is actually what we did, and I'm sharing you against a lot of this thing. This woman in the next cycle was given 5 milligrams. And what happened is, again, once her dominant follicle was 15 millimeters with a thin minnow, we said, let's try giving her a Progranova. Added her, though it's not suggested, and we did get a lining which improved, but it didn't go much beyond 6 millimeters. And then we triggered her at just 6. I remember it was not more than 6.2. And what was that the patient did conceive? I just want to say that, yes, we all believe that this is theoretically not possible. But yeah, sometimes when you talk to the patient or you feel, no, let's add some bit of, aspirin or something, which in real evidence doesn't work. It does work. So, and this patient is following up. She's currently 16 weeks pregnant and she's ongoing with us. So basically, we want to say that in the realms of evidence, none of these things are supposed to be, they are all suggestive. They may be effective, may not be effective in thin endometrium, we do say. But really in PCOS, will they work? Not really. But we had just got one beautiful case report, and this was basically a case report coming from China, where they did, in a patient of PCOS, they got a pregnancy even with the endometrium as thin as 3.8 millimeters. So, successful pregnancy was reported, basically highlighting that it's not just the thickness, it's the receptivity which also plays a role in thin endometrium. So let's go on from the PCOS to another group where we are actually doing ovarian stimulation, not induction. That is unexplained infertility. So it's a case of unexplained infertility. We worked her up. She had HSG done. Semen was normal, married for 3 years. And she's planned for ovulation. Now, again, I want to ask you, unexplained fertility, what is the choice? What would you all prefer? Everybody has their choices, likes, dislikes. So anybody, or let's hear from everybody, what would they choose?
Ovulation induction in the first 3 cycles. If she's not responding, we will assess the tubal pathology also.
We've assessed. Look, I just don't know. We've done it. She has her tubes. HSG showed fill and spill. The semen was absolutely normal. She ovulates. The serum progesterone rises. Everything was dug up. She's unexplained. Let's not waste time there. We are not.
And for
4 cycles of ovulation induction,
Sorry?
probably with 4 cycles of ovulation induction with clomiphene or letrozole. And if she does not conceive, directly go for IUI.
Okay.
Would like to add a gonadotropins.
Gonadotropins
Get
also,
multiple
yeah.
follicles.
But no need of.
So if I say choices and unexplained, how many would say CC? How many would say letrozole? How many would say, or all say gonadotropins?
I would first prefer letrozole.
A combination of letrozole and gonadotropins.
Absolutely.
Letrozole and gonadotropin.
Okay. So everybody, absolutely right. We all have our choices. And here is something which I think we all are very, very keen to start gonadotropins. And I would want to purposely got this because there is a little bit of change in evidence, and I would share you what is the evidence. So we basically gave her, I think I can, yeah. So we gave her letrozole, and she did get a dominant follicle, and we triggered her, went a little longish on day 15. So we gave her letrozole. Now, I just got this purposely because till a couple of years back, we, okay, I wouldn't stop. We will come to the part of discussion later, but I'll just share you what happened. So, she was actually, we triggered her, and what we did, when we followed her on a day of IUI, she was planned for an IUI, we found that there was an unruptured follicle. It was LUF. And the ET was showing diffuse pattern. Do you see this common with letrozole, or you see it with CC, or you don't see it at all? I want to ask this.
Ma'am, we see it rarely, and that too with CC cycles, not.
Yeah. So this was a surprise to us. As I said, I'm getting you all the real patients. This was a picture, This was when we did. And normally, a lot of people question you, why do you do an IUI? Why do you do an ultrasound? Well, we definitely do an, ultrasound before we are pushing and preparing even the semen, washing the semen. And this was a typical look. So she had not ruptured. So what would you do next? Would you sort of abandon, call her next? Do you think you can salvage? You can do something in this cycle?
Madam,
This cycle has
the
to
thing
be
is that
abandoned.
Madam, even if it appears luteinized unruptured, often it could already be in the early corpus luteum state, and we can still go ahead with the IUI. But if we are really feeling that she is going into a cyst formation, decapeptyl trigger can be added in the next cycle, or as added as a trigger along with HCG. Here 10,000 HCG is given, madam.
Yes.
Often in cycles where very high dose HCG is given, especially in people with unexplained or people who are prone for cyst formation, this occurs. So if we plan a decapeptyl trigger in the next cycle, that would be better. Or as a rescue, we can try a decapeptyl again this cycle, but a good luteal phase support should be given.
Right. Thank you, Aswati, for getting this. I think that's what I wanted. Doses are little 5,000 work. So probably, we thought we've given 10,000. That's the reason. And that's what I wanted to be brought out. So she is LUF. We don't know whether we should go in this next cycle. Well, in the current cycle, you aptly said you could add a decapeptyl agonist. But what if the agonist also doesn't work? Do you think in the next cycle you could do something different? Anybody?
Double trigger can be given.
Yes,
She's
madam.
unexplained. She's unexplained. She's unexplained, mind you.
Dual trigger can be given.
Okay, dual trigger. Or would you like to change the stimulation only? Or do you think
Yes,
because
everything can be changed, madam. We can try a different regime for her, follow her up, give her a different trigger, and see whether she is ovulating with that.
Okay,
a proper corpus luteum appearance is coming.
Great. So would you like to change the stimulation, or you change everything, or you would say, I'll just change the stimulation and go with HCG?
Generally, if he is responding well to a particular ovulogen, then I generally change the trigger and see.
Okay. So I think we have all the combination permutation. You all have answered it perfectly. So, it's as Right said, can we salvage? We maybe do nothing. As somebody said, maybe she has ovulated. This could be that. Absolutely. Could be repeating a trigger, or we do a dual trigger, as you already said, or sometimes even give Ovitril. Maybe Ovitril works. That's the way it is. Yes, what could we do in the next cycle? We could probably change. We could probably give a combination, give her a letrozole with HMG. As we do a sequential stimulation, we could do HMG alone, or we could do, as rightly said, a dual trigger. I just got this, there's some Japanese studies where they have even given GCSF as prior to the trigger. So, a few hours before they give subcutaneously granulocyte stimulating factor. However, they are very small studies and I didn't want to get them in detail. That is just a very big query. And yeah, many times when you don't get, or you get a repeat LUF, you are better off doing an IVF in such patients. You do encounter repeated LUFs. But then it's important that before you really jump on to the next cycle, we should actually look at some conditions where we are bound to see, LUF, and I think hyperprolactinemia should always be ruled out. But sometimes a hyperprolactinemia is actually picked on in an unexplained infertility where it is answering the question as LUF. So these are some things I thought we should answer. So just a kind of study in which they have done, CC plus HMG and letrozole plus HMG in IUI cycles. And they said there was 2 groups of LUF was lower in the letrozole HMG as compared to, this is one study which is a randomized study in which they were looking at the prevalence or the chance of LUF, and they found letrozole gives lesser chances when combined with HMG as compared to CC with HMG. So I just thought that we'll go ahead with this unexplained bit in another woman, and I'll just tell you what are the newer things that have come up. So again, another, woman, the couple is unexplained. Everything's normal. BMI is just borderline. AMH is not very good, but not bad either for a 36-year-old, 2.3. Our AFC in total was 9. And the tubes were patent, semen was normal. She had actually been planned for IUI with us. So do you think, considering that she's age 36, 5 years of unexplained, do you have any plan in place, or you feel you should go similar, just offer a IVF, or you should, no, I can still try ovulation induction and IUI, or just ovulation and time intercourse?
Ma'am, we'll counsel the patient regarding the AMH as it is on the lower side. And depending on, we'll offer them that we can directly go for IVF. But if the couple is not willing, we can try 1 or 2 cycles with IUI and then go for IVF.
Yeah. Check the previous cycle reports, like how the IUI has been done properly from a good place. So if it has not been done, then maybe we can try it.
She never had any. She never had any IUI. She never had any ovulation stimulation. There was no history. She was no treatment history. She's come as a first time to us. She had no treatment.
Definitely we can try, ma'am. We can try with
definitely try IUI, but counsel her that she may need an IVF because of her advanced age. And an early IVF would be better rather than like delaying it maybe beyond 37 years.
The average value of AMH, definitely we should not prolong, like we should not keep on doing IUIs because of her advanced stage and borderline.
So how many stimulation do you think you can give her? Just 1, 2, 3, 4, 6?
Maximum 3.
2 to 3.
Maximum 3, 2 to 3 cycles.
If the patient is fine, 1 to 2 good cycles is also
maximum.
Yeah, I think this is what I want to hear. Don't think that in the rules of the book says 6 IUI or 6 stimulation, I should wait, because I think it's again patient's decision, but we should at least drive her to say, look, we'll just try maybe 3, not wait for 5 or 6, and we'll take a call early. Thank you so much for getting this right there. So we basically gave her a stimulation with letrozole. Why I got is, I wanted to tell you that changing, paradigm shift in stimulating agents of, unexplained fertility. The guidelines have come up from ESHRE also, but we know that this is what we have to look in, whether she ovulates, tubes are patent, cavity is normal, semen, and of course, nowadays we should say, even though the ESHRE guideline says you don't need ovarian reserve testing, but I say we need to test ovarian reserve. If you look at the SRM in 2020, it says ovarian reserve testing. ESHRE in 2023 says there's no need, but I think in our setup, we should certainly look. So I just thought I'll get this. In 2015, we had this landmark paper, which came from Diamond and Legro's group, where they actually compared letrozole, gonadotropin, or clomiphene for unexplained fertility, and they all came out with this large multi-center trial saying that letrozole is the best, because it's best because it did not only give comparable pregnancies to gonadotrophins, but it gave lower multiple pregnancies. So, between the cost effectiveness, letrozole was better. So we felt that letrozole matched exactly. But if we look at the guidelines that have changed and the trials that have come now, they say that unexplained is a group where you can still offer CC. So I think as we are drifting in PCOS and other conditions to letrozole, I think CC still has a play, and there are a lot of papers which are suggesting CC becomes the first line. However, even letrozole stands equal. I again say the choice of going again initially to gonadotrophins should be there, but then again, depending on patient's pocket, it's very important. And it's not recommended to use low-dose gonadotrophins IUI, because we found that the gonadotrophins in most of the studies from this ASRM guideline said that the efficacy of gonadotrophins in unexplained is as good as CC. So why spend extra cost and land up with multiples? So this is what is also a strong recommendation from ESHRE, that stimulation is recommended for couples with unexplained. That means just doing time intercourse is not better. In unexplained, there may be some subtle male factors also, which will be overlooked. Just offering ovarian stimulation doesn't. So a stimulated IUI is better. And if it's stimulation, then I think CC stands as good as, or letrozole stands as good as gonadotrophins. So let's come on to, I think this should be the last case, because we are running fast. We are running, ahead in time. So this is primary infertility 4 years. This girl is a HH. She had not told her family. This is very typical, of when they get married, the husband also doesn't know. She's been on E+P right from her childhood or her teenage years. She has withdrawal bleeding, which is good. She's come to us and she shares that she was amenorrheic from a adolescent puberty, no history of infertility, and she basically wants a baby. We just got her hormone profile, typical FSH, LH, HH. So where do you think you would help her? What investigation you would like to do? Just go straight for gonadotrophins, or you still want to work her up? Anybody? Suma, Raghavendra, anybody?
Ma'am, actually, we need to get the whole hormone profile. Like we need to see the prolactin and definitely a karyotyping. Because she's having all the enzymes on the lower side. So all these we need to evaluate, and if we plan for a stimulation, we have to go for HMG, because we have to give a combination of FSH and LH, because all the hormones are to the lower side.
Okay. So when you really start, would you like to talk to this woman and her husband in confidence, something before you start HMG, or you feel, no, it's going to be okay, we can just talk to her and then get away?
Madam, in this case, counseling is very important, because we'll be right away starting with gonadotrophins. So we have to counsel the patients and then only go for a treatment.
We'll be starting with a slightly higher dose also. So, higher dose and then step down, really would be better. And
yeah, you want to start a high dose. Yeah.
Longer duration of treatment, the higher the cost of treatment. And also we'll have to evaluate the endometrial response also, because she still may not, the endometrium may not respond adequately even after giving so many doses of HMG also.
We would like to assess the male factor and make sure that the tubes are patent also before we
Yeah,
go ahead
that's
with the
yes,
expensive course of treatment.
yes. Absolutely. This is a case where I can't do without a tubal testing. So if you go for the ASLM guidelines, when you use gonadotrophins, especially in HH, it's mandatory to test their tubes. Unlike, where situationally the clinician chooses, patient doesn't want. But here, semen and tubes are must. And I think you all have pointed out that counseling is very important. Not only that she may go long, I've had patients who are ovulated as late as 32 or 35 days. And something which we should tell them that, again, I always say the first cycle is always a trying cycle. Don't think you've not had OHSs. I have seen patients referred to me with OHSs even in HH. So don't think HH will not have a hyper response. So, the first cycle is always a trying cycle. It's like, you do a test drive. So again, something which you don't do, don't trigger them with agonist or anything, but you need only HCG. And also be very mindful, don't trigger them when you have more follicles. So I just thought I will get you these very quick, recaps. So this patient was actually started with 75. We do a typical step-up regime, gave it small doses. She did not respond. We gradually graduated up and went up. And, when we were giving up, we told her all this. And ultimately, on day 20, we realized that we even needed to go up higher. We titrated it to 225. So this is something where I want to say that even on day 20, when she did not have a dominant, I had the guts and I said, no, let's go ahead and give. So these can be places where you are getting a patient for the first time, you don't know. So first cycle has to be very importantly counseled. Look, we are titrating your dose. We may take longer time in your first cycle. And the second cycle may actually be faster. So again, I want to know what is the maximum dose you can give. Again, this patient had an AMH. We finally had to go up to a 300. And again, I want to ask, when do people get a response? Do you think you would start back with the dose that you got to begin with, or you would start again with the lower doses?
We'll start with the higher dose.
We would start with a higher dose and tell them that there is a risk. It would be better that they should be ready to convert to IVF if multiple follicles start recruiting together. In such scenarios, madam, when they are responding to the high dose, the moment we start reducing the dose, the cycle just may not go ahead. The follicles all regress sometimes. So it would be always better if they are willing for an IVF conversion also, if that is the only way she is recruiting.
Yeah, absolutely. Yeah. This I want to tell when you see too many follicles, don't retract, because if you recede, it'll just be a fallout. So this is where I wanted you people to tell, I think the plan should be when she goes with a high dose, be prepared. And before you do that, tell the couple we may need to convert it to, because these women give you picture perfect embryo, oocytes, good oocyte, good quality, and also because they responded well. But be mindful OHSS can, because I've managed 1 or 2 OHSS very way back, maybe 10, 15 years back. Of patients of HH going into hyperstimulation. So basically, I think Priya has already covered which are the kind of patients who are generally HH variants, gonadotrophins, and second line therapy. Rightly said, IVF is there. And these are some of the checkpoints that we do. We are precautious. We start them with this is the first cycle. Important thing is luteal support. These patients definitely need a luteal support. You have to give them a good E+P. They will not have a pregnancy unless you give that you already talked. So I'll just thank everybody and end the panel. And I think if there are any questions, we'll be happy to take the questions. Or I know all of us are exhausted. We are looking forward to dinner now. And so I'll just end here by saying that ovulation is a challenging situation in some cases, and I therefore got some scenarios. Any of the panelists has some experience to share, we'll be very happy to take it from you all also.
Ma'am, just a doubt. Do you give a higher dose of HCG in hypo patients?
No, I generally keep myself to 5,000 only. If there are just 1 or 2 follicles, I don't need to push. And again, anything between 5 to 10,000, depending on, again, there's no data, but BMIs do affect. And one thing I think, a lot of time you get good pregnancy, 25% pregnancy rates. Again, I give the choices of IUI to add with timed intercourse to my patient. When many times patients say, well, we are trying so hard. Is it necessary you should add the cost of IUI? Can we try? I always say it's better to do an IUI because we are very confident that, IUI would actually increase the options or chance of pregnancy. But I have not increased the doses as such.
Madam, one more thing, like if your patient does not respond to our extended letrozole, like for 10 days, is there any possibility of giving it for more number of days? I heard in some conference that some people give it even up to 21 days.
Yes,
things like that.
Yes. Yes. See, if you look at the fertility study papers, they gave the extended letrozole for, they started giving for 10 days. That's how it was. And there's a stair step in which they keep increasing. But at the end of the day, there are some kind of small studies which had come up, but as such, we don't have very big data to say that you can extend it for 21 days. In that case, I might as well, rather than, it's not the cost of the tablet, it's the cost of even monitoring. So might as well come back and give her a combination of letrozole or with HMG rather than push her to 21 days or 25 days. In my experience, I really don't feel very happy on extended letrozole therapy. I've rarely used it.
What about the estrogen pre-treatment for the hypogonadotropic hypogonadism?
Yes, very good. I would like to say here, most of these patients, and this is a dictum, I should have got this as a slide. Remember, if there's a patient who's hypo, even if she's taking E plus P, which she takes, make sure that at least for 2 to 3 months, at least 2 months, she takes an E plus. She continues. The reason is that addition of estrogens, not in the increased dose, the standard dose, increases the responsiveness or sensitivity of those receptors to gonadotrophins. So, if she's off by any reason, get her, Obviously, another thing which I forgot to tell, when you do HH, make sure that you measure the size of the uterus. We do get patients who have taken E plus P, left it. What happens as soon as they leave, the uterus, shrinks. So I have to really get them, in these cases, I never begin a stimulation with gonadotrophins if the uterine size is less than 6 or 6.5. That's what I've learned with experience. And there's no harm giving for 3 to 6 months extra to get the uterus at least to 6.5 and then start.
And one more thing, in the hypo, don't miss out the life-threatening hyperprolactinemia with a microadenoma, macroadenoma. Don't miss out
Yes. These are typically cases of secondary hypo. I'll share you, we've got patients who come to us referred from our endocrinologist. They have got craniopharyngiomas, they have gamma knife, and then they become secondary hypo.
It's not rare.
Yeah. So they're not rare, because they are the ones who are actually on replacement. So she's getting a replacement for everything because she's just, it's a hypo plus she's getting other replacements, thyroid and then thyroxine. Yes.
And don't leave them after a pregnancy.
Yes.
Please give hormone replacement.
And I would add here, these are the ones where they would also need a bromocriptine also. They would actually be sometimes because of their treatment for their macroadenomas, even on bromocriptine. So you should not keep that also in mind. So that should also be factored in, not gamma knife, but otherwise, because of hyperprolactinemia, she's secondary. So in such cases, if they are on cabergoline referred from my endocrinologist, I switch them from cabergoline to bromocriptine because I may need to continue that bromocriptine even into pregnancy. So that's another thing which I would get a lot of, we do get a lot of referrals like this from our colleagues from endocrinology. So these are secondary hypo. Another thing which I learned when it's a secondary hypo, do give them a bit of estrogen priming at a month or 2. That helps.
And one thing which I would like to add is that whatever said and done, in spite of all the stimulations, all the hormone assays are normal, obesity is the single most reason where you find everything fails. See, all FSH, LH, AMH, everything is normal except for the BMI. And we may in spite of increasing the dosage of gonadotropins, she will not respond. And sometimes on a fine single day, she may burst with a lot of follicles when you escalate the gonadotropins. So here at this point, rather than telling the patient, you reduce weight, she will not reduce weight. But we have to help her with the proper physical activity as well as dietary advices with a proper physiatrist and dietitian is a must. Otherwise, they will not be able to reduce weight because always the calories, the supply is more than the demand.
Very rightly said.
Dr. Moideen, can we administer GLP-1 antagonist weight loss drugs? Are we supposed to, or endocrinologists are only the person who can prescribe?
Basically not, I think, better because the physical activity and the calorie expenditure is the best thing. Even the lighter versions of bariatric surgeries can be considered, but like the gastric thing and all can be considered, but certainly that has to be done with a caution because that can cause a lot of deficiencies.
And I would always say do it in joint decisions with your endocrinologist, bariatric surgeon, because this is one thing which I would not step on that.
Yeah.
The newer drugs are there, but we don't know how good, how effective, what side effects, and how would they have a bearing. So,
and to the extent guidelines say it should be an experimental thing in terms of fertility.
Yes.
So are we supposed to tread that path? Because the endocrinologists are the people who are well versed in that and who can counter the side effects. Do we know enough the side effects?
Actually, we don't know the side effects of many of the drugs what we are using now. See, not even the antagonists what we are using, we don't have the long-term follow-ups. So just leave alone the things which we use very less.
In fact, I've had a patient who underwent a bariatric surgery to realize that while she was undergoing, typically you get his surprises. Bariatric surgery had prolonged cycles of 60, 70 days. She didn't realize that when she underwent a bariatric surgery, she was actually pregnant because the urine pregnancy test was falsely negative. And when she didn't have, so, it was such a big challenge. Again, one place was weight loss. We reported this case is accepted there now, will be there. So, we realized there are only 10, 12 cases done like this. And imagine a 130 kilo who is told to lose weight is actually pregnant. And everybody said terminate the pregnancy. He said, no, this is a precious pregnancy. Let go on. Who knows? She may not become pregnant. Her AMH was just 0.9. And she was all 36-year-old, was planning a pregnancy. So, you do get surprises. So, we have to really walk a tightrope. We delivered a normal vaginal delivery for this patient while she was 138 at the time of delivery.
And the weight reduction is again difficult for a patient who has crossed 35 than for a patient who is in 20s.
Absolutely.
Because their basal metabolic demand itself is low. So they had to really work hard to get, see, the same thing can cause your IVF cycle also fail.
Yes.
Anyway, obesity is a big challenge.
So I'll just end here. Thank you very much. Thank you very much for all your patient hearing and your cooperation, and of course, all the help that you've given in Kunjumadin sir to get me onto this panel and moderate this interesting session.
And best wishes for you.
Thank you. Thank you so much. Thank you so much.
Best wishes, ma'am.
Thank you, Neena ma'am, and the panelists for the interactive and informative discussions, and of course for all the take-home messages which would be applied for our practice. So coming to the end of the program, no duty is more urgent than that of returning thanks. So I request Dr. Reggie to render the official vote of thanks.
Thank you.
Thank you, Neena madam, for that wonderful, insightful panel and sparing a weekday for us, for Kfog especially. And I would like to thank all the panelists to name Raghavendra Prasad, Soumya Nair, Priya Narayanan, then Sandhya Krishnan, Ashwati Kumaran, then Raihin and Suma Vishnu for sparing their time. I would like to thank our own president, Dr. Kunjumadin, Dr. Subhash, then Sujitra ma'am, all the chairpersons, speakers, Sangeeta, especially Sangeeta, she has done a lot of work over here. Thank you all the delegates for joining on this weekday, and hope that something fruitful has come into your practicing life. I think our conference went on well. So much of take-home points are there. Thank you once again, and till we meet again for another webinar. It's goodbye and good night. Thank you very much.
Good night.
Thank you.
Dinner will be provided at your home.
Thank you.
Typical of Dr. Moideen.
Okay. Thank you. Bye.
Kunju, are we getting packed dinners on from?
my dear kept packed.
Yeah. Thank you.
Thank you, Neena madam. Thank you, panelists.
Thank you, madam.
Everybody
Thank
look
you,
out for
Dr. Reddy.
Swiggy.
Thank you,
Swiggy is
Kunjumadin.
getting us. Bye. Good night.
Good night.
Thank you, Sangeeta. Bye.
Thank you, ma'am.